Dealing with enzymes, we will know that all that we have learned so far from regarding enzymes are very little than what you are going to use actually in medicine. In the field of medicine, so we will learn the basic difference between the catalyst and enzymes. So enzymes can very closely may be defined as the term called biocatalyst, but it is not the exact definition for enzyme. Enzyme is something which resembles the function of catalyst in many ways, but not in all the ways. Am I clear to convey the message? When we say biocatalyst, so it is not just biological catalyst. It is something else which is new, which is unique in the field of chemistry, which is not a part of chemistry, but there is an interface of chemistry and biological science. So the closest word which we can use instead of enzyme to describe its function or nature is biocatalyst, but it is not the exact definition. So enzymes are enzymes. Enzymes name, as you know, the history of name of the enzyme, how it came. We go for this comparison between catalyst and enzyme. Catalyst and enzyme. Now these initial few slides will help you to understand the relationship between catalyst and enzyme. The difference between catalyst and enzyme. Correct? So what are the similarities? Why we call it as biocatalyst, the second part? The second part, catalyst, may be used for enzyme because of these reasons. Both are needed in minute quantities. As we know, chemical catalysts are required in very small amount. They cannot initiate reaction. Neither catalyst nor enzyme will initiate any chemical or biochemical reaction. Whenever we use enzyme, we must use the contemporary word as biological reaction, not chemical reaction. Fine? It remains unchanged after reaction. Mostly 99.99% in cases, enzymes as well as catalysts remain unchanged. Both of them are involved in decreasing activation energy. What is told, correct? Activation energy is an energy which is a barrier for production of product from substrate. So it helps to reduce the activation energy. Combined with substrate during reaction. They do not telepathy. They interact. They share close interaction with the substrate. It is not like at home when you suppose one guest comes and you say something which is should be avoided, and your mom says, So this tele-reaction are missing in this case. They must interact. Means unless they slap you, you won't stop telling the unavoidable truth. Correct? So they must share physical interaction, both the cases. Otherwise, reaction will not take place. Reactions catalyzed are reversible. This is a basic law of any chemical reaction. Any reaction is reversible, provided all the conditions are maintained. Now, if so, then what are the differences? The chemical catalysts react in a very extreme condition. Say, for example, Haber's process of ammonia production. What is the atmospheric pressure? 2 atmospheric pressure, 370 degrees Celsius. So these are very extreme conditions. Enzymes do not react at such extreme conditions. What is the normal temperature for most of the enzymatic reaction? 37 degrees Celsius. This is our body temperature. What is the normal pH at which they act? 7.4. Mildly alkaline. 7 is neutral pH. 7.4 is the pH of blood or intracellular fluid. So, mildly alkaline condition they react. So, enzymes react at much milder condition compared to chemical catalysts. Which one is having higher speed? The catalytic reaction or biochemical reaction? Enzyme catalyzed biochemical reaction. Obviously, the biochemical reaction. I'll give you one example. At the time of birth, what was your weight? And after 1 week of birth, what was your weight? Your weight was doubled within 1 week. Huh? How? Such a huge speed. How fast the enzymatic reactions can be compared to any chemical catalyzed reaction? Any idea? Yes, 10 to the power 6 times, at least, if not more. It is so fast. But still, even though they are very fast, rapid, but they are heat labile. They are susceptible to high temperature. Any example that high temperature reduces enzymatic activity? Yes? Hyperthermia, hyperpyrexia, fever. Have you heard? What happens when you have fever? We are not given foods like biryani, butter masala, chicken masala, rejala, mutton kasa. Why? Have you ever seen any fever patient taking this kind of food? Why? It seems it is difficult to digest. So because of high temperature, the enzymes may not be at highest activity point. So we should be given easily digestible food. Correct? High specificity, the most important point. In a chemical process, most of the industries survive on this point. There are many industries which produce chemical compounds. Most of the industries, they survive for production of ancillary products, means additional products. Suppose A plus B reacts to form C plus D. Now the company made this factory to produce C, but D is produced as a byproduct. Fine? In many cases, it has been found that the amount of D is much more than amount of C. Means the byproduct is more, but actual product is less. For example, sodium chloride. Sodium chloride, the common salt, what we take, is a byproduct produced in chemical plants. So they are producing huge amount. But that is not our goal. We don't want to produce sodium chloride, we want to produce something else. So actually the resources are wasted in producing byproducts which are having less cost, less price. But in case of enzymatic reaction, this is avoided. Being highly specific, they always produce the desired product. Suppose glucose plus ATP in presence of glucokinase, they produce glucose 6-phosphate. They never produce glucose 1-phosphate or 2-phosphate. Never. Correct? Clear? So specificity is one of the points which differs enzyme from catalyst. Last point, once the process, chemical process is started, initiated, it moves on its own. But we can regulate enzymatic reaction. So for example, if we take a heavy breakfast, and we take very small amount of lunch and small amount of dinner, do we suffer from self-digestion? Because morning our body calculated that this fellow has eaten 15 breads. So afternoon also he will eat 15 breads or some equivalent food? No. So whatever amount of food is there, they will digest that. It will not overproduce. Who will regulate? Scope for regulation is available. Whatever is required, they will produce according to our metabolic need. This regulation point differs again enzyme from chemical catalyst. So high speed, specificity, scope for regulation, and milder reaction conditions. 4 points. Remember? Now, nature of enzyme. Mostly enzymes are protein in nature. Till end of the last century, we discovered that there are many enzymes which are not actually protein in nature. Actually, the first enzyme which evolved in nature was not at all protein in nature. The first enzyme which probably has evolved in our nature was not at all protein in nature. It was nucleic acid in nature. So the enzymes which are nucleic acid in nature, we call them ribozymes. Okay? Can you give one example of ribozyme? Peptidyl transferase, responsible for production of peptide linkage. Responsible for production of peptide linkage. See how basic theory it is. Enzymes are made up of protein. So enzymes cannot synthesize protein. Why? Because they are themselves made up of protein. So initially must be enzymes were not protein. That's why they could produce few peptides which later on took up the charge for these enzymatic reactions, for enzymatic property. Understood? কিছু ছিল ইনিশিয়ালি নিউক্লিক অ্যাসিড, তারা কি করলো? তারা কিছু প্রোটিন তৈরি করলো। পরবর্তীকালে যেরকম ওই কি বলে দৌড়ানোর সময় ওইটা দিয়ে দেয় না ব্যাটনটা ওকে হাতে দিল, এরপর থেকে যা যা এনজাইমেটিক রিয়াকশন হবে তোমরা করবে। নিউক্লিক অ্যাসিড হাত ছেড়ে দিল। আমি কি করবো? খালি আমি প্রোটিনটা তৈরি করার জন্য যদি প্রোটিন লাগে তাহলে সেই প্রোটিনটা কে বানাবে? To synthesize peptide, if we require peptide, then who will make the peptide? God? No. Nature. So it is made by the nucleic acid. So first evolved is nucleic acid evolution. Nucleic acid produced peptides. Then those peptides took up the charge to form many other forms of enzymes. Okay, same properties has been mentioned here. Now, different parts of the enzyme composition: apoenzyme and holoenzyme. What is holoenzyme and what is apoenzyme? The protein part of the enzyme is called apoenzyme. What do you call the non-protein part? Cofactor. So apoenzyme plus cofactor is equal to holoenzyme. Protein part plus non-protein part. Now, when this cofactor is organic in nature and can be separated from the enzyme via dialysis. What is dialysis? Separation of solute particles or purification of solute particles from a solution using semi-permeable membrane pouch. The same thing occurs in our kidney. When kidney fails, we take help of external dialysis unit. although the external dialysis unit is much less efficient than what we are given. So slowly the person will die. Initially they will require once in a 6 month dialysis, then slowly they will require twice in a 3 months, then once in a month, then once in a week, then twice a week, then thrice a week, and then they meet the Almighty. Fine. So like this. So this dialysis, if we can separate those cofactors by dialysis, we call them coenzymes. Now these coenzymes are nothing but derivative of different vitamins. Different vitamins. Try to pronounce this word vitamins as vitamins, not vitamins. Try. Vitamins is a old usage of vitamins. Okay. Is always try to pronounce as vitamins. So vitamins, they are responsible for production of these coenzymes, and this is list. You should be able to remember this list anytime. Okay. So what is the coenzyme form of vitamin B1? Thiamine pyrophosphate. TPP. What is the coenzyme form of vitamin B2? There are two, FMN and FADE. Okay. What is the coenzyme form of niacin? Two, NAD and NADP. What is the coenzyme form of folate? Plenty. Tetrahydrofolic acid. So it is N5-methyl, N5-N10 methylene, N5-N10 methinyl, N5-N10 formyl, N10 formyl. So many points. Huh? B6 or pyridoxine, coenzyme form PLP, pyridoxal phosphate. In olden days, say around 40-50 years back, if you have purchased any book, if you have any biochemistry book 40-50 years, published 40 to 50 years back, you would have seen this PLP written as PALPO, PALPO. Okay, so this name was given by some Indian scientist, rather Bengali scientist. So in the olden books, the olden teachers, they used to say PALPO. Now we say only PLP. So our well-known city, Calcutta, was very known for these discoveries of regarding PLP. Anyway, then lipoic acid, lipoamide, coenzyme A is pantothenic acid, is a vitamin. Okay, like this, biotin. Now, this one you should be able to recall and reproduce in the examination. The structure of enzyme can be divided into. There are some enzymes which contains no additional cofactors. They are simple proteins. Some enzymes, they are complex or hollow enzymes, protein plus non-protein. The non-protein part is called apoenzyme, and non-protein part is cofactor. Cofactor organic called coenzyme, inorganic called prosthetic group. So what is the difference between prosthetic group and coenzyme? Coenzyme is loosely bound, can be separated by dialysis, and organic in nature. Prosthetic group, inorganic in nature and tightly bound, cannot be separated by dialysis. So mostly it is seen that there are certain metal ions which are associated with the structure of the protein. Metal ions can be associated with enzymes in two ways. They might be a part of the structure itself, or they might be required for their function to perform. So for example, zinc is an integral part of carbonic anhydrase. What is the enzyme? It dissolves CO2 in plasma, in both plasma and RBC. Clear? So zinc is an integral part. Now, chloride is required for activity of alpha amylase. Chloride is required for activity of alpha amylase. If you remove the chloride from the intestinal content juice, the amylase will not function. It won't be able to digest carbohydrate. The moment you add little of sodium chloride into it, it will start reacting again. So like that. লেখা গেছে এটা? লেখা গেছে? Now, mechanism of enzyme action. How enzymes act. Almost each of the slide represents one important question from enzyme. This is another important question. Mechanism of enzyme action, or how enzymes act. Okay, try to understand the question very carefully. You have to understand what they want to know from the question. How enzymes act. Mechanism of enzyme action. When it's asked, you must describe under this topic heading. What is that? First of all, lock and key theory. Second, induced fit theory. And lastly, preferential transition state binding theory. Preferential transition state binding theory. Now, lock and key theory and induced fit theory were given by Emil Fischer and Koshland successively. And this was given by Dr. Philip and his co-workers, a group of scientists together. This is latest. In 1990s, it came up. Okay. Before that, we all studied these two only. Lock and key and induced fit models. Means how enzyme, what is the model of enzyme activation or enzyme action? How enzymes interact with the substrate and they perform the enzymatic reaction. This is the question. Okay. So we have three models: lock and key, induced fit, and preferential state binding theory. Preferential transition state binding theory. Okay. Lock and key model. The diagrams are very much needed to explain. See the diagrams. This is enzyme. This is substrate. So my question is, which one is bigger in size, enzyme or substrate? Enzyme. Can you give an example of the reverse? Usually enzyme is much larger than the substrate. But obviously there is exception. What is that? You have heard any exception? Anyone? Can you imagine a substrate very long? Very long substrate. Yes? Try. It's very easy, you know, all of you know. Yes. Protein. Okay, fine. Protein can be taken. Something else. Nuclease. Nucleic acid is much bigger than their digestive enzymes. DNAs, RNAs, they're very big, long molecule. But DNAs and RNAs are very small compared to that. Just recall the picture of replication, transcription. Enzymes are very small compared to the whole DNA molecule. Then you might ask me, why didn't you accept the example of proteolytic enzymes? Because proteins are very big. You see, chicken leg is such a big thing. No. In case of protein, the substrate is defined as a bond. The substrate is defined as a bond. If the bond is available within the active site of the enzyme, it will react, otherwise not. That's why we need to boil and cook the meat before eating. Otherwise, it will take longer duration to digest. We can digest, but it will take long time. Sometimes we may not digest, may not be able to. Why? Because of the process of evolution, we have lost such strong acid or such strong enzymes which is available among carnivorous animals living in the jungle, like tiger, hyena, wolf, dog, cat, etc., etc. They're all like that. But we have evolved through the process of cooking. We cannot digest. That's why our teeth is much smoother than any dog or any cat. Next. So in this lock and key model, what message he conveyed is enzyme and substrate are just like a lock and key. Can anyone tell me what is the material from which this lock and key are made up of? What is this? Is it metal or non-metal? Plastic? Wood? What? What would you prefer to make a lock and key? Metal or wood? Wood. Wood. Cart. Have you ever seen any lock made from wood? No. Why metal? No. They prevent any change in their shape. They are rigid. So what message they want to convey by using this lock and key is that both enzyme and substrate are rigid at their interface. Interface. F-A-C-E. Interface. Interface নয়. F-A-C-E. মানে এই রিজিয়নটা where it interacts with the substrate. Enzyme's active site where the substrate sits. So mostly they are complementary by their physical shape. Means wherever there is bulging, there will be deep curvature in the other counterpart, so that they can fit very closely. Fine. So both are rigid. Both are rigid. A newly wedded bride, when he enters to his in-laws' house, the mother-in-law says, "This is our custom that the brides from our family always keep a long veil." Ghomta, eto boro. But the problem is, unless you maintain this, you won't be accepted as a bride of this family. Problem. Understood? You have to maintain. There is no other way. This is the first case. You cannot change. Problem is, if so, then we have different proteins from different sources, different people from different religion, different caste, different creed. They have different dietary preferences. Some people take this kind of meat, some people take those kind of meat. The moment I change my religion from Hindu to Islam, I will start taking beef. And if I take beef, the very moment, because I have converted to Muslim, our body will start producing the enzymes which can digest beef. The moment when Muslim convert to Christian, his body will start producing the enzymes which can digest pork. Otherwise not. Correct? Is this feasible? This was the problem. If we need proteins from different sources, we need those many different enzymes. Enzymes for beef, enzymes for mutton, enzymes from sheep, enzymes for fish, for egg, separate enzyme. Now imagine how many types of eggs we have. So there lies the problem. So is it possible that God will come to know the moment we will change our religion and will start producing? Suppose morning I was Hindu, afternoon I was Muslim, and evening I became Christian. What will happen? In 3 times I need 3 types of diet to survive, because the Hindu enzymes will not follow. But the Muslim enzyme will just suddenly start. I am not giving this example from my own. This was the actual problem regarding explaining this model. So they came up that it is not possible that all enzymes follow strictly this rule. So they came up with this. Because if you keep this much of veil, you cannot walk. You will fall, you will stumble over. So reduce the length of the veil. So you can see your feet, you don't fall. So induced fit model said the enzyme's active site substrate is same, whatever it is. But active site will slightly change its shape to accommodate different substrate. Same enzymes, protein from beef, protein from mutton, protein from tilapia, protein from ilish mach, protein from golda chingri, protein from bagda chingri, protein from shol mach, protein from puti mach. All proteins will be digested by a single enzyme by slightly adjusting its active site. Now this is much more feasible. This is much more feasible, and this reduces the previous controversy. Clear? So induced fit theory was immediately taken into consideration. But do you know which one came first? This one. Then it was changed to lock and key model. Then it was again changed to induced fit model. See. The active site is slightly flexible. They bring about subtle changes. Subtle means small amount of changes, SUBTLE. Subtle changes in the active site to accommodate different closely related substrates. Clear? That is induced fit model given by Koshlands. Now this model is much more consistent with a wider range of enzymes. Fine. The bride can walk, and also the familial prestige can also be maintained by keeping the veil, by just reducing the little height of the veil. Both in-laws are also happy, bride is also happy. Right? Now, problem came when this theory arrived. By late 90s, or about late 80s, there were different scientific mechanisms, processes by which we could freeze and take photograph of molecules. It came long back in 1952. The first important discovery of this process was the structure of DNA. Anyway, but in the late 70s or 80s, it became rampant in using or understanding the different structure of protein or enzymatic reaction. So what these scientists do? They initiated a reaction, then freeze the reaction, at that state and then took a photograph of enzyme attached with the substrate during the reaction process. What they found is striking. The structure of enzyme, the structure of substrate was not that actually it had before the reaction started. That means the native structure. The shape of the active site was not at all it had before the reaction was started. Followed? The active site shape was different, which is consistent with induced fit model. So it can change, fine. But the substrate structure is also changing. This was new. The first theory was neither substrate nor enzyme. No one will change. Second one, substrate will remain constant. Enzyme's active site will change slightly to accommodate it. Third one, both enzyme and substrate, they change. Enzyme's active site also will change a little bit and substrate also will change a little bit so that they can fit together in much better condition. They can fit together much better condition. Both have to change. Okay, this was a theory. Now, when they took the photograph of that enzyme and substrate linked with each other, they found a new theory called transition state theory. Transition state means neither the substrate is substrate nor the substrate is converted to product. In between, the enzyme will have more physical complementarity with the substrate at its transition state. Enzyme active site will have more physical complementarity with the substrate at its transition state than its native state. The native structure of the substrate is less complementary with the enzyme's active site compared to transition state. How to prove it? It was found in many reactions that inhibitors designed against the shape of the transition state of the substrate inhibits the reaction more efficiently than the active substrate. Understood? By this method, they came to know the transition state theory is that. Okay? So here we must mention, see, so both enzyme and substrate after their structure is subtle changes structure and with the transition state structure of the substrate compared to with the transition state structure of substrate compared to the native one. So far what you have studied? You have studied the difference and similarities between catalyst and enzyme. 4 points to remember. Short questions. Next, properties of enzyme, nature of enzymes, nature of enzyme. It may be protein or nucleic acid in nature. Next, how enzymes act, 3 model. Okay, and enzymes composition or structure, apoenzyme, holoenzyme, coenzyme, cofactor, different coenzymes and their biological derivatives. Fine. Now we will know how the enzymes are named, the nomenclature. The nomenclature of enzymes begins with understanding of this classification. Enzymes are classified into how many classes? Enzymes are classified into how many classes? 6. Achha. If you have purchased a book of latest edition, you might find 7. Yes, very good. Okay. So it came long back, but there was controversy, so it came a little late on the when they published. book, published form. So what was the seventh one? Translocase. Very good. So if you write 6, then also you will get marks. If you write 7, then also you will get marks. If you write 7, that doesn't mean you will get more marks. Why? This is not neat. Here we are not going to throw you out. Here we are going to pass all. So we will take more acceptance than rejection. So what is important to remember here? The sequence. The sequence is constant. OTHLIL, oath, lil. Oxidoreductases, transferases, hydrolases, lyases, isomerases, ligases, translocases. So two things to remember: constant sequence and the plural form, oxidoreductases. With the number of enzymes are there in the same class. Now what are these classes? We will see. We'll come to that EC later, EC, Enzyme Commission. So classification, biochemical activity, what are these? Oxidation and reduction reactions catalyzed by these enzymes. Either addition of oxygen, removal of oxygen, addition of hydrogen, removal of hydrogen, addition of electron, or removal of electron. Either of these reactions will lead to either oxidation or reduction of the molecule. Now we know wherever there is oxidation, there is simultaneous reduction of the another molecule, because they always exist simultaneously. So oxidoreductases are those enzymes which participate or catalyze any kind of oxidation or reduction reaction. Enzymes ending with dehydrogenases, oxidases, reductases fall under such classes. Fine. Now here you have to remember one general example and one specific example. General example, you can say like, এখানে আবার নতুন জায়গায় এটা আছে পেন আছে এখানে general example, like you can say suppose A plus B বা A plus H, A plus B বা A B কি একটা পেন থাকলে ভালো হয়। আচ্ছা পেন আছে, লেখার পেন, আরে লেখার পেন আছে? Achha. Suppose A, B, well, compound is there, you put one H and then put arrow and then write AH plus B. That means hydrogen is added to with A. Yeah? So it is reduced. So this kind of reaction is general reaction followed by a specific reaction. You can give example of this. Lactate dehydrogenase, pyruvate is converted to lactate and vice versa. Transferases involved in transferring groups. So this is general reaction of class 1. Then specific reaction is that pyruvate dehydrogenase, you can say. Transferases, we just added one group to A. So for example, glucose plus ATP, glucose 6-phosphate. Example is alanine transferase, alanine and transaminase, alanine plus alpha glutarate to form pyruvate plus L-glutamate. Hydrolase. When we split a large molecule using water. How using water we are splitting a large molecule to AH plus BOH. Okay, this kind of reaction is called catalyzed by hydrolysis. Example, all digestive enzymes. All digestive enzymes. Now, since it is a class of enzyme, there can be alpha amylase. এই দুটো ফর্ম হয়, একটা salivary, একটা pancreatic. Maltase, lactase, isomaltase, sucrase. ঠিক আছে, গেল রেনিন। ঠিক আছে, এবার প্রোটিনের দিকে আয়। এই কার্বোহাইড্রেট গেল, তাই তো? প্রোটিনের দিকে আসো, প্রোটিনের দিকে আসো। পেপসিন, ট্রিপসিন, কাইমোট্রিপসিন, কার্বোহাইড্রেট A, কার্বোহাইড্রেট B, ইলাস্টেজ, তারপর কোলাজিনেজ, ইয়েস, ভেরি গুড। তারপর এন্টারোকাইনেজ, ডাইজেস্টিভ এনজাইম নয়, ওটা ডাইজেস্টে হেল্প করে। ট্রাইপেপটিডেজ, ডাইপেপটিডেজ হলো। অ্যামাইনোপেপটিডেজ, কার্বক্সিলেজ বললি না, অ্যামাইনোপেপটিডেজ বলবি না, হলো। এবার আয় লিপিডের মধ্যে, লিপিডের মধ্যে একটাই বলি, লাইপেজ। হ্যাঁ, আর জানিস না লাইপেজ। হ্যাঁ, ঠিক আছে, তো একটা হচ্ছে গ্যাস্ট্রিক লাইপেজ, একটা হচ্ছে আর জানিস না তো? দেখ আমি বলি, এবার তুই দেখ, আমি বলবো তো সব জানবি। ফসফোলাইপেজ A, ফসফোলাইপেজ B, ফসফোলাইপেজ C, ফসফোলাইপেজ D, ফসফোলাইপেজ A2। তাই না? এগুলো কি? সেরামাইডেজ, সব লাইপেজ, হ্যাঁ না? কত লাইপেজ, হ্যাঁ না? ডিএনএস, আরএনএস, তাহলে হ্যাঁ, তাহলে এটা আমার খুব একটা প্রিয় কোশ্চেন ছিল, 20খানা ডাইজেস্টিভ এনজাইমের নাম বলো। আমি কতগুলো বললাম? 20টার বেশি আছে, ব্যাস হাতে হারিকেন, আর কেউ বলতে পারে না। দেখ খুব সহজ, কিপ ইউর মাইন্ড ওপেন, আইজ ওপেন, है ना? Learn this chapter of enzyme. Our goal to know maximum number of names of enzymes. Fine. Okay. So we go to hydrolase. Then এটা লেখা হয়েছে lyases. আচ্ছা, we'll stop here. Don't hurry. We'll stop here. Lyase বলে দিই, তারপরে যাচ্ছি। Lyase means splitting of large molecule without water. This is lyase. Splitting of enzyme, splitting of product, substrate in two parts without water. It's called lyase. Example, aldolase, carbonic anhydrase, fumarase. এই aldolase, দেখো fructose 1,6-bisphosphate is split into two half, desaldehyde 3-phosphate and dihydroxyacetone phosphate. The fourth step of glycolytic reaction. Isomerase, interconversion between two. The general reaction is like this. Isomerase, है ना? Same compound, but arrangement is different. Example, mutase, racemase, isomerase. Alanine racemase. Alanine to D-alanine. Do we require D-alanine in our body? No. Who requires? Bacteria. ligases, joining. Ligases, joining. এক জায়গায় ligation মানে কিন্তু কাটা, এখানে ligation মানে হচ্ছে joining. তো ছিল এরকম। opposite to ligase. কিন্তু বেশিরভাগ ক্ষেত্রে দেখা যায় এই জয়নিং এর জন্য একটা বাইরে থেকে এনার্জি লাগে, এক্সট্রা এনার্জি না থাকলে সাধারণত এটা হয় না। ঠিক আছে, এক্সাম্পল ডিএনএ লাইগেজেস, তাই না? ডিএনএ লাইগেজেস। আর এখানে কত এক্সাম্পল দেওয়া আছে, অ্যাসিটাইল কোয়ে কার্বক্সিলেজ। যে কোনো কার্বক্সিলেজ রিয়াকশনে সবসময় মনে রাখবে কোএনজাইম লাগবে, কি? বায়োটিন আর এটিপি। গ্লুটামিন সিনথেস, very very important reaction for holding or capturing the free ammonia in the body. It occurs in the brain. It removes free ammonia from the brain so that our brain remains all okay.
What I want to say that whatever for practical notebooks you have 2 marks or 5 marks, it is very important. But if you submit a blank sheet, we have no path to give you a mark. If you were in my position, then what would you do? So don't take it very casual and easy, because 15 marks, 10 marks for spotting and 5 marks or whatever it is there in your syllabus. So this is one, what to say, I bringing things into your notice. You enjoy life, enjoy everything, but don't leave it for Kal hobe. Don't do it. And your 2 hours and 3 hours you are in the anatomy department in 5 days a week. So spend your, like Sopun Sir has told you, dissector's manual, if you have it. So 4 of you buy one dissector's manual. And whenever you are not going to dissect everything, but they will be showing you, our teachers will be showing you the parts. So when you are in groups, you please, after 10 students see or observe, again another batch comes in, another 10 students come in. But when you are, don't leave the hall. Or you stay, there are 3 places you can study. After your practicals are done, please sit in the demo rooms, okay, dissection hall, and see, evaluate, and have an atlas with you. Atlas, Times Atlas is very nice, I would recommend. And Grant's Atlas is there, but Times Atlas is very nice and beautiful. Now, this is one thing I have observed in the last batch, this thing. So I'm just telling you, then you will be in tension in the last moment. Today is the theoretical exam, and yesterday they are coming and saying, sir, please sign it. You don't be at the mercy of any person. This is one thing I tell you. Another thing, it's a long journey. You keep on carrying on the things, good or bad, whatever it is, in your journey. With all this beginning, I wish you all the best in future. And one thing, you become a good MBBS. A good MBBS is a good postgraduate. So you are having you will be, by the time you pass out, you will be having a 1,000 bedded hospital. So an ample number of patients in the urban, rural. What you don't learn in AIIMS, you will get the opportunity to learn in these rural medical colleges. So with this introduction, I'm going to, you have already exposed to, by Swapun sir and other teachers, that lower limbs. Now today, my talk will be on the venous drainage, and the lymphatic drainage of the lower limb will be covered by another professor tomorrow. Now, and don't bunk classes. If you, when you are in the habit of reading till 2 a.m. in the morning and then going to bed and you're squeezing your pillow and not coming bunking one physiology class or bunking one anatomy class, don't do it. Now, 3 sets of veins are there: the superficial, deep, and perforating. Now, when you dissect in the lower limbs, you will be seeing that superficial just below the skin, then the deep and the perforating. Now, the deep venous system with the superficial venous system, it is connected with perforators. Now, superficial vein lies in the superficial plane, and great saphenous and small saphenous veins. You will see the great saphenous vein when you see, if you tie a tourniquet, then over here you will see it will swell up. And also it represents the preaxial and postaxial veins of the developing limb buds. When you read embryology, a chalkoidy. Anyway, now in embryogenesis, when you see in your embryology book, you will see that the 2 limbs are protruding. And over there, the preaxial and postaxial veins are developing limb buds. Now, deep vein, surrounded by powerful muscles enclosed in deep fascia, accompanied by arteries and include tibial, peroneal, popliteal, femoral. Now, these are the large vessels, the arterial of the lower limb, and below knee, arranged as a pair of vena comitans. It's in connections below the knee. Above knee, from a single major vein. And now, deep vein surrounded by powerful muscle enclosed in the deep fascia. It is in the vein, it pumps the muscles of the limbs over here. It pumps and goes to the heart from the lower limbs. Okay, and perforating veins communicate superficial with the deep veins by piercing deep fascia and following intermuscular septa. Now, when you see a cross section of the thigh or cross section of the leg, you will be seeing in your thing that the vein, it communicates with the superficial vein, is communicating with the deep veins, and it pierces the deep fascia and following intermuscular septum. The muscle groups are separated, intermuscular septum. This is the content of the deep fascia, and it is like this. You think of cutting your thigh, in the mid-thigh. Then you will see the muscles in a plane, and it's separated by septa, the deep fascias. Okay, and valved at each end and permit blood flow from superficial to deep veins and not in the opposite direction. You mark this because I will give you some clinical pictures, show you some clinical pictures where you will the varicose veins and veins from the Veins from the muscles draining into deep veins are valved except those in the soleus where they are arranged as venous sinuses. Now, as you go and dissect, there's a soleus muscle in the leg. Now, that has a different pattern and it is venous sinuses. Okay. Now, perforators in the lower limb. Now, this is the superficial circumflex iliac vein, the medial vein of the thigh, the femoral vein, the anterolateral vein of the thigh, long saphenous vein, this is the long saphenous vein, and popliteal vein, anterior vein of the leg, this is the anterior vein of the leg. Okay, posterior arch vein, gastrocnemius perforator. Now, I will tell the perforators. Now, this is the venous pattern. Now, the medial vein of the thigh, the mid-thigh perforator of Dodd. Mid-thigh perforator. There is a perforator in the mid-thigh, and gastrocnemius perforator, Boyd, the name of the anatomist who discovered or who dissected out and saw the is Professor Boyd. And lower leg perforators, this is first perforator, second perforator, third perforator, and this is cocket. And ankle perforators may or coster, this is the ankle perforators. Now, this is the very important, there will be perforators of the lower limb, can be a short note. Just mark, okay. And now you see, it will be shown in the dissection, the perforators. Now, the femoral vein and the mid-thigh perforator, gastrocnemius perforator, lower leg perforator, ankle perforators. Now, one thing I tell you, you just, if you forget, the perforators, a short note is there, or 8 marks or 10 marks or 5 marks. Now, in case you forget the name of these anatomists, don't bother. You just draw a diagram and point out at the mid-thigh perforator, then the gastrocnemius perforator, and lower leg perforators, and the ankle perforators. You will be given marks. It is not necessary and mandatory to remember all the scientist's name or who is the inventor and all this. Don't get obsessed with this. I have to remember this name, or suddenly, all of a sudden, you ask the teacher, "Sir, what is this?" Don't do this. You just have it is there. Anatomy is there in the body, in your books. So you can just you see the illustrations, and whenever you are reading, you draw diagrams. Just rough sketch, not become a Kalabhavan artist of Shantiniketan. It is not. You have to convey your message. See, Americans are very bad in their handwriting. They just scribble or just put like this. So, but the message is there. You draw a diagram, at least it will be a normal thickness of the thigh and a normal thickness of the leg, and it will be a normal foot. It won't be a filariasis of the leg. You have seen god. Okay. In Bengali you say it is a filarial infection of the limbs, and it can be the hand, it can be the leg also. Now, perforating vein. Now, venous blood of foot flows from deep veins in sole to superficial veins on the dorsum of the foot. In leg and thigh, venous blood flows through the superficial to deep veins as directed by valves of perforators, and 4 perforators are present in the lower limb. You correlate the previous picture with this description. Now, ultimately, actually, we were quadrupeds. Chatushpad, which chatte pa. Then slowly with the evolution, you will be, it's an erect posture. That's why inguinal hard ears are very common in human beings. But elephant, being such big mammoth structure, a structured animal, but hard ears are not common. Not common means nahi practically. So because of the evolution of posture, now you imagine it is a 4-legged animal, say the dog, or any 4-legged animal. The blood supply is going in a certain height and then it goes into the heart. But as the evolution of erect posture is there are many things which happen that doesn't happen in an animal. Now here's another beautiful picture showing the saphenous vein, and this is the mid-thigh perforating vein. This is the around the knee joint, gastrocnemius perforatus, and the posterior tibial perforatus, okay, and medial perforatus of the foot. Now, you study anatomy, you see your friend's body, your friend sees your own body, you lift up the thing, and you can see everything. You can see the hand. When you read the hand, you will see the movements. What is the movements of the foot, and the movement of the ankle joint. When I told you after 10 p.m. having dinner, you sit in groups, have an atlas, have a books, have one big notebook, and just draw diagrams and discuss. It is not your kindergarten days where you used to study alone and your mom says don't share anything. It is the time now that you believe in teamwork. A cardiothoracic major person who does the main surgeon, but he is helpless without the OT sister. Because when you do a neurological operation, then there are at least 60 to 70 swabs, like the earbuds. You have seen the earbuds, there will be small swabs. Now, before closure, the OT sister checks that if these 60 swabs are out. So, and your surgeon, your assistant, it gives you. Similarly, you read anatomy for 2 months, what I am telling you, after dinner, before that, physiology, biochemistry, whatever you have, and that 7 days or 10 days you are doing your preventive and social medicine or community medicine, you please finish those notebooks, whatever you have to deposit, do it. But now as dissections have started, you please concentrate, and one thing I tell you, there is enough material. If you forget to bring a book, please, in the wall of I would request, all of you have visited the museums of the anatomy department? Who have not visited? Please raise your hand. All have visited. But that visit was a casual visit. But from today onwards, you go, if you have an opportunity. I would say that if you have not procured bones, now after your osteology, say lower limb, femur or hip bone, there is, you go to Suresh, he will issue you a femur or 2 femurs, and you take it from him and study in the demo room. And again return that to him, he will sign, You just tell him, even today I will tell him to, if there is a dissection, I don't know if there's dissection, but I think there's anything you have. But your anatomy department, museum, and the bones which you have in the Almeida, please use it. It is, most of them are plastic bones, but teachers will be demonstrating on human bones, and you study, at least you can see the upper end, lower end, head. A fine linea aspera and plastic bone, it will be thick. But if you can't identify a bone, like if you tell the femur humerus, like someone said the sternum sacrum, it happens, but this ignorance cannot be said that, no, I don't know. The sternum is saying, he or she is saying sacrum. Sacrum is this part. So, now positions of the perforators. Now, the mid-hunter perforator connects great saphenous vein with the femoral vein in Hunter's adductor canal. Now, John Hunter, you will see a portrait of John Hunter in the dissection hall, extreme east wall. You see that poster, and if you search in Google that who was John Hunter? John Hunter was a school dropout. His brother was an established surgeon and anatomist in London. And John Hunter, anyway, he lived a life in a very bad way, going to brothels, drinking, whatever it is. But one summer, he told his brother, used to run a center in the London. So he asked his brother that, please, brother, I want to join you and just give specimens, and whatever you tell me to do in the lab, I will do to the students, with the students. And John Hunter what he did, he surpassed his brother, and he wrote 13 volumes of different surgical and anatomical, comparative anatomy, embryology, all these books with illustrations. And that was his journey, and till date, Europe or modern surgery has not produced a surgeon of the caliber of John Hunter. So you can imagine that you can do it. And see now the positions of the perforators. Now mid-Hunter perforator connects great saphenous vein with the femoral vein in Hunter's adductor canal. When you dissect the thigh, there will be the canal, that is known as the adductor's canal, the adductor muscles forming that canal, and that is named after John Hunter, dissected out and said after his name, it is John Hunter's adductor canal. Now, knee perforator connects great saphenous vein with posterior tibial vein just below the knee and close to the medial border of tibia. Now, as you read this osteology, tibia, now you will be seeing that posteriorly, the order, when the body is turned, you will be see on the posterior aspect, you will be dissecting the popliteal fossa, and skin superficial fascia, there will be the popliteal vein. And One lateral ankle perforator communicates short saphenous vein with the peroneal vein and situated at the junction of middle and lower third of leg. Three medial ankle perforators connects great saphenous vein with posterior tibial veins and joins with one another by posterior arch vein. A upper at junction of middle and lower third of tibia, lower situated below the behind medial malleolus, and middle intervenes midway between them. Now, when you read a bone, now perforator veins, again I have showed you the same illustrations. Now, peripheral heart or the calf pump, that we were saying that the muscles in the calf, they compress and pumps the blood towards the heart. Okay. Now, in upright position, contraction of the calf muscles with deep fascia squeezes the blood upwards along deep veins. Competency of valves in perforating veins prevents reflux of blood into low pressure superficial veins during contraction of calf muscles. Now, great saphenous vein, the longest vein of the body, represents the preaxial vein of the lower limb, begins as a continuation of medial end of dorsal venous arch of the foot, supplemented by medial marginal vein. You see your own foot when you go to the hostel, and you will see the you tie a tourniquet and see the anatomy of the vein, and passes upwards in front of the tibial malleolus, medial border of the tibia, occupies posteromedial aspect of the knee, joint and patella. Medial side of the thigh is to reach saphenous opening, fossa ovalis, which lies below and lateral to the pubic tubercle. Now, as you have not read your hip bone, the hip bone has a pubic tubercle, symphysis pubis is here. Naturally, just and both two hip bones are there. So over there and just below it, a saphenous opening is there. You will be seeing in your dead body, and that it's a oval opening. There where the great saphenous vein is draining. Now, passes through the saphenous opening after piercing the cribriform fascia and finally drains into the femoral vein after piercing the femoral sheath. Now, the femoral sheath is here, the cribriform fascia is just as when if the body is very well preserved, then you can find it out and see it. Well, the teacher will demonstrate to you. Okay. Now, this is the common femoral vein. This is superficial circumflex iliac vein. This is the superficial epigastric vein, external pudendal vein, anterior accessory saphenous vein, the great saphenous vein. Here it goes. See, as the description previously, it was like this. The medial malleolus in front, it goes straight. Posteriorly, it goes to the tibia, and then again it covers and it comes in the front. Okay? And the great saphenous vein. Now, here you will see the saphenous opening, femoral sheath is here, and the one or two lymph nodes, and the long saphenous vein. This is the inguinal canal, and the reflected part of the inguinal ligament is this part, and this is the pubic tubercle. This is the superficial ring, and this is the femoral sheath here. Now, structures accompanying great saphenous vein. Now, great saphenous vein in the thigh, few branches of medial femoral cutaneous nerves. At knee, saphenous branch of descending genicular artery. In leg and foot, saphenous nerve. The saphenous nerve is posterior to the vein at knee, but in front of the vein at ankle. Now posteriorly it is the posterior to the vein, but in front in the ankle. Now tributaries of the great saphenous vein just below the knee. Posterior arch vein collects blood from posterior medial aspect of the calf and consists of series of venous arcades connecting three medial ankle perforating veins. Anterior leg vein extend diagonally across the shin and joint great saphenous vein. If you see it, it will be going like this, diagonally. And a few veins from calf which communicate with small saphenous vein. Now, in the thigh, the tributaries of the great saphenous vein in the thigh, anterolateral vein commences from the venous plexus on lower part of the front of the thigh, crosses the apex of the femoral triangle and joins the great saphenous vein in the upper part of the thigh. Posteromedial vein, sometimes called accessory vein, drains the posterior and medial aspect of the thigh and joins with the great saphenous vein. Sometimes communicates with the small saphenous vein. Now, tributaries of the great saphenous vein just before piercing the cribriform fascia and the fossa ovalis is the superficial epigastric, drain blood from lower part of the abdominal wall below umbilicus. So below umbilicus it drains the lower part of the abdomen. Superficial circumflex iliac drain blood from the lower part of the abdominal wall below umbilicus. Superficial external pudendal drains part of the scrotum and receives blood from superficial dorsal vein of penis. So the scrotum, the penis, it drains into superficial external pudendal and accompanying corresponding branches of femoral artery. Now tributaries of the great saphenous vein, thoracoepigastric vein, runs along anterolateral wall of the trunk and occasionally connects superficial epigastric vein with lateral thoracic vein, establishing a communication between femoral and axillary veins. Deep to saphenous opening, deep external pudendal vein passes deep to the spermatic cord after draining blood from the anterior part of the perineum and finally terminates into great saphenous vein before latter opens into the femoral vein. Now veins draining into the inferior vena cava, the common iliac vein, internal iliac vein, external iliac vein, inguinal ligament is here. Okay. The femoral vein, great saphenous vein, superficial. Popliteal vein, small saphenous vein, fibular vein, anterior tibial vein, dorsalis pedis vein, here this dorsalis pedis vein, and dorsal venous arch, and dorsal metatarsal veins. It is the venous drainage and the arterial supply that it has to drain. Okay, naturally the configuration is such that every portion or every area is being drained, vascular drainage. It might be a venous drainage, it might be arterial supply. Now, short saphenous vein begins below and behind lateral malleolus, continuation of lateral end of dorsal venous arch, supplemented by lateral marginal vein of the foot. এগুলো সবই তুমি দেখতে পাবে নিচেতে, নিজের পায়ে দেখতে পাবে. It is there and ascends along lateral edge of tendocalcaneus and is accompanied by sural nerve on lateral side. Now tendoachilles, you know, this part, tendoachilles, it is in the side, it comes from the dorsum of the foot. The arch is formed, by the venous arches. From your toes, it comes both sides of each toe and then forms an arch and then goes. Now, runs along back of the leg, pierces deep fascia and undergoes subfascial course between two heads of gastrocnemius until it reaches the middle of the popliteal space, where it terminates into popliteal vein. So I told you earlier that the popliteal vein, when you dissect the popliteal fossa, the two heads of the gastrocnemius muscles are there, and over there it is draining. When you go into deep dissections, you'll be knowing it. Here the femoral vein, the great saphenous vein, tributary with the lower saphenous vein. Accessory saphenous vein is, and small saphenous vein is this popliteal vein. Here's the popliteal vein. This is draining here. The short saphenous vein, variability is in termination. Sometimes joins with great saphenous vein in the upper third of the thigh, either directly or through accessory saphenous vein. May bifurcate, one joining great saphenous vein and other ending in popliteal or deep posterior veins of the thigh. Occasionally fails to reach knee and ends in great saphenous vein or deep veins of the leg. Provided with 7 to 13 valves. Now, clinical applied. Now, these are the varicose vein, varicose ulcer, aortico-coronary bypass operation, venesection of the saphenous vein, Trendelenburg's operation, and stripping of the varicose vein. Now, these are varicose vein. Superficial vein of lower limb are often dilated and tortuous and becomes varicose. You will see many people are having their veins are very tortuous and swollen up. Sometimes there is varicose ulcer, pigmented and suffers from lack of nutrition and cause varicose ulcer which bleeds profusely. Now, causes: thrombosis of deep veins, persistent elevation of intra-abdominal pressure due to abdominal tumors or multiple pregnancies, incompetency of the valves in perforating veins or superficial veins. Now, these are the causes of varicose veins. So, incompetency of the valves in perforating veins or superficial veins or both. Persistent elevation of intra-abdominal pressure due to abdominal tumors or multiple pregnancies, and thrombosis of the deep vein. Here's the picture. See, this is the before and after. Now, this tortuosity. And photos courtesy by Robert Min, MD, Cordal Vascular Surgeon, New York. And this is after the surgery. Okay. Now, if the varicose veins, if a patient presents you with minor, it is not like this tortuous or not, but she might be complaining of pain, of if there is ulcer, first go for a conservative. There are varicose stockings from the here to up to the thigh. And try to, you advise the patient that foot end of the bed. Now you have two bricks or two wooden this thing to put the foot end elevated, and where the stockings at bedtime you open it, allowed to open it, but from morning to night, in between, of course, gaps, and also some now varicose ulcer. Over the area of varicosity, the skin becomes pigmented and suffers from lack of nutrition and cause varicose ulcer, which bleeds profusely. Now, if you get a case with this ulceration, first of all, these vascular surgeons are not available everywhere. Okay, and these are highly specialized centers who are performing. So at least you are in a rural hospital, or you say in your own medical college, a patient come with a bleeding, you please survey and then put a bandage, dressing with some antibiotics, okay, and manage the patient. And aortico-coronary bypass operation. In aortico-coronary bypass operation, great saphenous vein with some of the tributaries is removed for arterial grafting. Due to presence of valves, vein has to be reversed to replace an arterial obstruction. So the saphenous vein is harvested. We use the word harvested, and for coronary bypass. Venesection of the saphenous vein, the saphenous nerve should not be included in the ligature around the vein. Now, nowadays you are having some fine needles like Gelco and all these different companies having a different name. You can, like if a patient coming in shock, you have to give an IV infusion plus a blood transfusion, and she's literally in the verge of death or something like that, or presenting in a shock state. Then previously you used to do a venesection, but nowadays these needles are there. But if at all, you say don't, because old is gold. You have to figure out the vein over here and dissect out and take two sutures and just lift up the vein. You make an incision like this. You make a vertical incision and then put aside the skin, pull the skin. Then you dissect out the artery, sparing the nerve, vein, and sparing the nerve, and then you loop in. This small suture you put it, and like this, and then you make a small, with a pointed blade, you make a small incision there, and you put that catheter, and that connected to the IV fluid or your blood, whatever is at your disposal. Now, Stendelberg's operation, incompetency of saphenofemoral valve throws great strain on more distal valves, and whole great saphenous vein becomes varicose. The great saphenous vein is detached from the femoral vein at this point of entry, and tributaries in the groin are ligated individually, otherwise varicosity will recur. This is a method, this is the very nice picture. Normal one-way vein valves. See, blood flowing to the heart this way. Now, healthy valve permits reverse blood flow, prevents reverse blood flow. It prevents. If the valve closes, this is the blood flowing to the heart, varicose vein valves. Now, reverse blood flow due to damaged valve or incompetency of the valve, the blood goes down, and that leads to varicosity. Now, stripping of varicose veins. Now, this is a method of veins is done, identification of exact site of defective perforators. You have to detect, or whole length of great saphenous vein. A flexible wire is introduced into the vein from medial malleolus to the groin, where it is brought out of the superficial vein after disconnecting it from the saphenofemoral junction. In the previous picture, the saphenous, here is saphenous, and this is sapheno in the femoral junction. The wire stripper is pulled proximally, and entire vein is avulsed. Here is a picture. The stripper, this is the stripper, you see here. Stripper head attached to the end of the vein stripper, and calf incision being where vein stripper end exists and stripper head attached. Now, tourniquet test. Tourniquet test, recognition of sites of incompetent valves can be made by tourniquet test. The patient lies with lower limb exposed and affected limb is elevated above level of heart to empty varicose veins. তার মানে এইরকম শুয়ে আছে, পাটাকে একবারে তুলে দিতে বলে, lying down. Then that drain. Now the patient is then allowed to stand and produce gentle exercises. If varicosities remain empty for 30 seconds, the communicating vein below tubing are competent. When filling takes place within this time, the communicating veins are incompetent. When collapsed, veins fill at once on removal of tubing, the spinofemoral valve is incompetent. Now, this is normal vein, one-way valves, and the backflow, enlarged greater saphenous vein, direction of blood flow to the heart. Deep vein thrombosis. Now, the blood flow is sluggish in soleal venous sinuses when muscles are at rest. Prolonged rest in bed after surgical operation in some patients develop deep vein thrombosis and can use very severe complication, pulmonary embolism. Now, I tell you one thing, when you go to your clinics, your ward, you see any patient lying down after an operation. Now, what I make it a routine practice when I go on my rounds, I tell the attending person to massage. Now under spinal anesthesia, for at least any procedure in the abdomen or anything, the legs are, you can say, no sensation, paralyzed for 3.5 hours or 2.5 hours. And then you ask the patient or nurse to lift up or fold their legs and then just massage to avoid this thrombosis, deep vein thrombosis. So you make it a habit. These are the teachings which I've learned from my teachers. So this is also a clinical based, now teaching is more important now, but you have to know the anatomy. এটা তুমি ধরো একটা দারুণ সার্জারি করেছো, পেশেন্টটা 6 ঘন্টা ধরে সার্জারি করেছো, রাউন্ডে আসছে এমনি করে দেখে মানে ভগবান দর্শন হচ্ছে আর কি। ডোন্ট, তুমি 6 ঘন্টা একটা অপারেশন করেছো, পারফর্ম করেছো, ইট ইজ ইয়োর ডিউটি টু জাস্ট স্পেন্ড 1 minute, 60 seconds with the patient attendant and also the nurse and just say এটা একটু পাটা ভাঁজ করে দিন, একটু দেখিয়ে দিন। আবার যদি কেউ গ্রামীণ পেশেন্ট, আমার ছোট্ট একটা হাসপাতাল আছে, তো সেখানে আমি পাশ ফিরিয়ে দিয়ে পিঠে তাকে ম্যাসাজ করা দেখিয়ে দিচ্ছি, বা অ্যাটেন্ডেন্টকে নিয়ে একটু থাপ থাপ করে মেরে দিলাম। These things you have to pick up. I'm telling you, you become a good MBBS first, and you will never look back. Why I'm telling you, it's the era of technology. Yesterday, one of your dada is asking me, sir, to abar anatomy পড়তে হবে। আমি বললাম anatomy সারা জীবন পড়তে হবে। বলতে এরপরে তো MCQ করে আমাকে পোস্ট গ্রাজুয়েট করতে হবে। আমি বললাম বাবু তুমি MBBSটা ভালো করে করো। A good MBBS এইটাই হবে তোমার মনের মধ্যে ডেকে নাও যে good MBBS is a good postgraduate. Few of them are in the anatomy department. You can see the embryology section. Before we are born, the title is given there. Over there, small embryos that no embryology will show you.
So today's class, it was supposed to be that already on Monday, history taking and general survey, you know the detail, know what is required to know, and today you will only practice. But as you are not looking that confident, I am discussing these things again, and clinical examination means clinical practice. Practice is required. Without practice, you will forget. If methods are wrong, in the first year of medical school, you are not expected to, as beginners, you are not expected to report your findings very correctly. They may be wrong, there may be deviations from what is correct. But methods have to be, at least basic methods, you have to know. Okay, in physiology practical in this batch, if you don't know till now, then there are 3 broad headings under which the whole physiology practical syllabus for your course is divided. What? Human and clinical physiology, hematology and amphibian physiology, and part of some discussions of cardiopulmonary resuscitation. Amphibian physiology, when we will do, you will come to know. So we relate amphibian nerve muscle preparations, findings from amphibian nerve muscle preparations. We don't have to do it anymore because there are issues related to ethics and all, this killing of animals and all. So amphibian experiments, just the findings, how do you relate it to human physiology? That is one part that will be done at the almost the end of your session. The session means this course, first year course. Before that, hematology. Sometimes human physiology and hematology may go side by side. Some weeks there may be human physiology practical, some weeks hematology, or maybe that after we come to the end, we have not taken a decision yet. We come to the end of this human and clinical physiology, we go to hematology. Hematology lab is that side. You are acquainted with the department a little bit by now. Okay, hematology lab room is that side. That is the clinical physiology room. There are 2 rooms, one clinical physiology, and there are instruments in the room beside this. This is the demo room, and here are the offices and the faculty rooms. Okay, so syllabus is human and clinical physiology, one broad heading under which the syllabus will be covered, and this includes this examination of arterial pulse, examination of blood pressure, history taking and general survey, and examination of the different systems, the respiratory system, the GI system, the cardiovascular system, and the nervous system. Whatever topics are there in your syllabus. Okay. And nowadays, for the last 3 years, NMC has introduced competencies also. You have to appear for competencies. That means you are competent enough to evaluate these things. The topics which will be discussed, those will be taken like small internal exams with few marks. Okay, and all these will average into your internal assessment marks. Internal assessment, at least 35% has to be scored to go through to the university exam. Otherwise, a candidate is not allowed to sit for the university exam without 35%. But if you get just 35% or maybe 40%, rest 10-15%, because 50% is pass marks, separately in theory, separately in practical. So rest 15% you to make up there. And if you do well in the internal exams, because we will take like, we teach few topics and then take an internal exam. Okay. So if you score well in that, maybe you get 60%, 65%, then those are covering your, ultimately you have to get 50%. So it is better if you do well here. Okay. It is not predictable whether how much, it is not possible to score 90%, 100% in a professional course like this. Here even getting 80%, 85 marks is very good enough. But you have to keep your target high. Okay, these are more of philosophical talks, but about the syllabus, human physiology or clinical physiology, hematology, that is the blood experiments with experiments related to blood. Hematology you are doing now in theory, and practical portions we will do here in the lab, physiology practical, and amphibian experiments. So out of these 3 broad headings, we have started with human and clinical physiology, and in that I thought we have covered examination of arterial pulse, you are telling you have covered examination of blood pressure, but if blood pressure is not done, then just pay attention. What is the name of the instrument which we use measure blood pressure? Sphygmomanometer. There is nothing to write, everything is there in the book. Okay. So which book you are following for physiology practical? The book by Dr. Pramanik. Okay, for at least I recommend for the beginners, you may use the book by Dr. A.K. Jain. All books are more or less good, all books are covering more, and these new books are being written according to what you need, okay. So they have, NMC has divided into competencies, but the book by Dr. Jain is a relatively old one. The book by Dr. C.L. Ghai is a very good one, but it is very extensive. So few months into your course, we will tell you what to read from C.L. Ghai. But if you go for C.L. Ghai now, you have to choose what to read, because it is not possible to understand all theoretical aspects just now at the beginning of your course. So I would recommend that you, and this book by Dr. A.K. Jain will help you in your finals also, okay. And for the beginners it is good. It is a colorful book. It is written point wise. The book by C.L. Ghai is a very good book, no doubt, but it is much extensive, okay. Theoretical discussions at the end of each this chapter are very extensive, so you cannot go into the details of those now, because you will not be able to understand. There are other books also, you may follow anyone. This is a professional book, no one is there to force you, okay. But I would say that book, even we refer to those books just because it is easy to access for short time information, for gathering information in a short time and remembering the salient points. That is a very good book, but you may use any book, but at least use one book, keep it dedicated for your reading your physiological practical portions. So sphygmomanometer is the name of the instrument. So see, if there is any medical person in your family, or somehow you have come to know that earlier nowadays they are going out of out of culture. That is the things in which the instrument sphygmomanometer, in which the mercury column used to be present. Actual mercury used to be present, but sometimes the instrument is broken by accidentally by during handling or something. Mercury may spill out like this due to some constraints. They have replaced it by this type of dial, where the graduations are the same, exactly the same as that in that mercury column. The graduations are written beside that mercury column. Graduations are same, and it is standardized according to the sphygmomanometer in which mercury column is present. So all these readings which are given here are in the unit is millimeter of mercury. Blood pressure of a human being is measured in units. Anywhere you have to mention a parameter, you have to talk about a parameter. In any science, also medical science, you have to tell a range, not just a number. Like pulse is not 72 per minute like in childhood. No, it is 62. Normal range is 60 to 100 beats per minute. There the unit is beats per minute. Here the unit is millimeter of mercury. Normal blood pressure is around 120 by 80. No, better answer is it is up to 140. Systolic blood pressure is up to 140. By you have not started with cardiovascular system theory? No. But there is something called systolic blood pressure, there is something called diastolic blood pressure. In short, we will come to know everything is cardiovascular theory part. But what is blood pressure? What is blood pressure? It is the pressure exerted by a column of blood flowing through a vessel on the wall of the vessel through which it flows. And the earlier we used to say lateral pressure. For your as beginners you may use the term lateral pressure, or it is the pressure exerted on the wall of the vessel through which a column of blood is flowing. So on that vessel wall a column of blood is exerting a pressure, that is what we call blood pressure. And what is systolic and diastolic blood pressure? Systolic blood pressure is the maximum pressure recorded during systole. Now what are the meaning of this term systole? Systole is contraction. Contraction of what? Contraction of the heart chambers. How many heart chambers are there? 4. 2 atria, right and left, and 2 ventricle. Whenever we have to speak of atrial systole or atrial diastole, diastole is relaxation of the heart chamber. Now when we speak of atrial systole or atrial diastole, we have to write the full thing, atrial systole or atrial diastole. Also, if we say ventricular systole or ventricular diastole, that means contraction of the ventricle or relaxation of the ventricle. But without mentioning the name of the chamber, if we just say systole or diastole, it means contraction of the ventricle, contraction or relaxation as it goes, systole, diastole. Systole, diastole means ventricular systole, ventricular diastole. But if you have to speak of atrial chamber systole and diastole, then you have to mention the word atrial, and just mentioning systole and diastole means ventricular systole and ventricular diastole. Now during the systole, the maximum pressure, there is the variation in pressure at each. Now this is a very short period of time. You will come to know in your when theoretical discussion should be done, the total cardiac cycle is only 0.8 seconds. So it is not measurable physically, but still there are variations in pressure throughout this period of systole. Out of that, some part is only systole, some part is diastole out of 0.8 seconds. Okay. Now in this systole period of systole, the maximum pressure reached, that is recorded as, that is defined as the systolic blood pressure, and during the period of diastole the maximum pressure reached, that is called as not maximum, the minimum pressure reached, that is called as diastolic blood pressure. So remember, maximum during systole is systolic blood pressure, minimum during diastole is diastolic blood pressure. Okay. So just by this basic foundation of learning, many things related to this chapter you will know when the theory syllabus is being done, the theory topics are being done subsequently. But for now you know this, what is systolic blood pressure, what is blood pressure, what is systolic blood pressure, what is diastolic blood pressure, and how to measure it, now we will come to know. So the instrument is sphygmomyometer. In this instrument, the dial is like this. It is standardized according to the graduations. These graduations are standardized according to the graduations beside the mercury column in the instruments. Sometimes still now used, but usually they are going out of use. Okay. So here the labeling is from 0 it starts and up to 300. So in above 300 millimeter of mercury blood pressure is abnormal, that means too high, that is a medical emergency. Even above 200, 220 is a medical emergency. So it is given up to 300. Okay. For outpatient settings, okay, in your clinical setup, up to 300 it is the maximum, and above 200 is that means the patient requires some emergency attention. And so this is the dial. So this is the cuff. Cuff spelling is C. This is one cuff. In medical science, this cuff is related to anatomy, calf muscles. Yes, but in medical science, there are calf muscles in the leg. Okay. And in medical terms, you have to use, for superior and inferior extremities, you have to know the parts. In superior extremity, what are the parts? That is not a part of today's discussion. From shoulder joint to elbow joint is the arm, form. Elbow joint to wrist joint is the forearm, and wrist is hand. Similarly, in the inferior extremity, from hip joint to knee joint is the thigh, from knee joint to ankle joint is the leg, and rest is foot. Now in this, there are calf muscles in the leg. Leg means that part between the knee joint and that. So the calf muscles, the names and everything you need to know in anatomy will come to know. Already inferior extremity has been started. So that is one spelling of this. Spelling is applicable there, but the spelling applicable here is CUFF. So this cuff is named after the person who named it. This is Riva Rossi cuff. This is for the Riva Rossi cuff. Okay, everything is written in the book. No need to write these things. Just listen. And this is for raising the blood pressure. Okay. Your dominant hand, most of us are right-handed, you use the dominant hand for using this part of the instrument. So this is but this cuff is called the Riva Rossi cuff. So these are the parts of the sphygmomanometer, and also to measure blood pressure we require this instrument called the stethoscope. We will come to know more of it in the respiratory system examination, but just we tell the parts because in the examination, when you are appearing for the examination, you have to tell the parts of most of the instruments which you are going to see in your syllabus. So very simple. This is the part of the stethoscope which you put in your ears. And how do you put it? How do you put it? Not like this. So this would be forwards and inwards, like this. Okay. So I am putting it like this, forwards and inwards, not backwards, not backwards. Okay. So this is how to put it. This part is the earpiece. There are two earpieces. Obviously we have 2 ears. So 2 earpieces. This is the body tube. Okay. And this is the common mistake which is occurring. This is the chest piece. So this side of the chest piece is the diaphragm, and this part is the bell. Okay. So this is the chest piece. So diaphragm is an incomplete answer, not wrong answer, but incomplete answer. If you tell only diaphragm, then you miss out this part. This is the bell. So bell is used to hear low pitch, softer sounds. So low pitch sounds, like example is murmurs of the heart. What is murmur? You will come to know later. Murmurs of the heart. And one classical example is fetal heart sound. Over the mother's womb, the fetus is lying inside. The doctor is noting, the clinician is noting the fetal heart sound. Okay. So we require for blood pressure measurement also. We hear the sound of the blood flowing through after blood flow has been obstructed through an artery, through a blood vessel. Then when the blood flow is again restored, then sound comes. Usually blood flowing through a blood vessel does not produce any sound, because blood flow is said to be, all these terms you will come to know in the theory class. Blood flow is laminar, that is called laminar flow of blood. No sound is occurring, laminar flow of blood. But once we constrict an artery and obstruct blood flow through it, when the blood flow is restored by releasing the pressure, we apply pressure over a blood vessel, we constrict it, and we don't allow blood through that part of the vessel or that vessel as a whole. We don't allow blood. Now when the blood flow is restored, now turbulence is created. That is turbulent blood flow, then only the sound is created. And again when the blood flow becomes laminar after some point of time, within few to several seconds, then blood flow again becomes laminar, there is no more sound. This principle is used in measuring blood pressure with the stethoscope. Now whenever we use stethoscope for clinical examination, the term which we use is, the method is called auscultation. Okay. So clinical examination, auscultation, A-U-S-C-U-L-T-A-T-I-T-O, auscultation. So in clinical examination we will come across these 4 methods: inspection, palpation, percussion and auscultation. Inspection is without touching or feeling the subject, your subject as a clinician, your subject with your own hands. Inspection is just by viewing. Palpation is by touching or feeling. Percussion is another type, a special type of this. What you do, you will come to know later. You use both your hands and do some kind of tapping, that is percussion. You require one finger of your non-dominant hand and another finger of your dominant hand, and we do percussion. We will come to know that. And then what is there to laugh here? Anything to laugh about? Why are you laughing? Inspection, palpation, percussion and auscultation. Auscultation is when you are using the stethoscope for any clinical examination, not only in blood pressure, any clinical examination, when you are using the stethoscope, that is the auscultation. Now blood pressure measurement will require 2 of these 4, palpation and auscultation. Just by inspection blood pressure measurement is not possible, just by looking at. Okay, so that is not possible. So palpation and auscultation. Palpation is PALPATION. So what we do is we tie this cuff over the arm of the person, just 2 inches above this elbow joint. Okay, this is the elbow joint and this is the ventral surface of our superior extremity. So don't put the hand like this. If a person lies down, then if the horizontal, you should be acquainted with terms, because in your whole medical life you will need these terms. So if a person is lying down, in the lying down position on a horizontal surface, then if the ventral portion, this is the ventral or anterior part of the body, and the posterior aspect is called the dorsal portion of the body. So ventral aspect, the dorsal surface is touching the horizontal surface and the ventral surface is above towards, say, the roof of the room. So that is what position? Supine, S-U-P-I-N-E. And if it is opposite, the supine, the ventral aspect is on the horizontal surface, ventral aspect of the body on a horizontal surface, and the dorsal aspect is facing towards the roof, then that is called prone position, P-R-O-N-E. So blood pressure is measured either in the supine position or in the sitting position. Okay, the person is sitting down, but if the person is sitting down, then the hands will be, the ventral aspect will be forward, okay, not backward like this. So the ventral aspect will face forwards, and if supine position, obviously the ventral aspect is facing above. So, and we are tying this cuff, the Riva-Rossi cuff. After tying the cuff, we have to ensure that all the pressure at that point of time is released. This knob has to be tightened, and now we start pumping this, and then this dial, it has to be set at 0. It is preset at 0. Now it is raising, and simultaneously this is, you are doing with your dominant hand. If somebody is left-handed, it is comfortable to use the left hand of the clinic, that is the left hand of the clinician over this, and with another hand you are keeping your hand on the arterial radial pulse. So the hand in which hand of the subject in which we are tying the blood pressure cuff, the Riva-Rossi cuff, say you have put it in the right arm, okay, put it across this right arm, over the right arm, and with your dominant hand what you are doing, you are pumping this, and with your non-dominant hand, your means the clinician what is doing with his or her non-dominant hand, putting the hand on the arterial pulse, like we have measured pulse with our 3 fingers. Examination of the arterial pulse is done 3 fingers, that we have put on the radial pulse. Now one time will come when by increasing the pressure, the artery, the blood flow is obstructed and the radial pulse will be obliterated. And our eyes will be on the dial. So we have to note that reading here. At the point of time when the radial pulse will get obliterated, probably your left hand is over the radial pulse, because most of us are right-handed, and if opposite, you are using the left hand on the pump and right hand. If anybody of us is left-handed, okay, then left hand is over this pump and right hand over the arterial pulse, this radial pulse. When at the point the radial, and you have to raise it very slowly, as slow as possible, so that at least as beginners, so that you don't miss the reading. So after the reading, you note the reading, say at 110 here graduation, that pulse is obliterated. Another 20 or 30 millimeter you raise, say 20 millimeter, and then gradually, slowly you release the pressure with the help of this knob. You release the pressure. Then what will happen? This will again come down, this will reverse the direction, this dial, okay, the direction will be reversed, now it will come down. Do it very slowly. Usually the point at which the pulse was obliterated, say at 110, again that pulse will come back at 110. It may differ 2 or 4 millimeter of mercury, say 108, 106, because there is some human error. 110 means it may have been at 108. These are very in a short space, there are many graduations, but it will not come like 10 or 15 graduations apart, it will not come. 110, usually it comes back at 110, and after you get that pulse back, you can release it faster. No need to do it slowly anymore. After you get that pulse back, you need to do. This reading is the systolic blood pressure, and this method which is used is the palpatory method of measuring the blood pressure. By the palpatory method, you get the idea about the systolic blood pressure. Okay. So suppose you get this reading at 110, then the systolic blood pressure of the person is systolic blood pressure. Theoretically, what is that? The maximum pressure is during the systole of the ventricle. You omit the word ventricle and say just systole, because systole means ventricular systole. Atrial systole, you have to mention atrial systole. So during systole, the maximum blood pressure is, that is the systolic blood pressure, which is recorded as this point, the graduation corresponding to the restoration of the obliterated pulse. Usually the point at which the pulse will get obliterated and the point at which the pulse will come back is that means the artery blood flow is restored and the pulse is coming back. Pulse will be recordable when blood is flowing. So the pulse will be calling back. Those 2 points are the same. That is, say in this case, in a person's case, we have got it as 110 reading. So the systolic blood pressure is 110 millimeter of mercury. So when we go to that room, we will how it is done. This is recording of the systolic blood pressure, and by what method? Palpatory method. Palpation or palpatory method. PALPATION is palpation. PALPATOR is TORY is palpatory. This is the palpatory method. Now what we do? The pressure has been relieved. The cuff is not opened. Okay, the pressure has been released, but the cuff is still in position. Now we take the stethoscope. Okay, and where we have to put the stethoscope on this ventral aspect of the elbow joint. That means this is the elbow joint, this part. Okay, on the ventral aspect of the elbow joint. And remember, ideally during measurement of blood pressure, you have to expose at least to the shoulder joint. Now in your physiology practicals, who is the subject? Say some staff from the department or your own friend. Okay, sometimes during the examination, because of matters of privacy, etc., the examiner who is taking your exam, okay, say do it over the clothings. Okay, but ideal what is? It is to be done over the, we will know why. It is done over the exposed arm. We have to tie over the exposed arm. Any clinical examination will require proper exposure. Okay, so ideally it is done, but it may be for your physiology exam, you may be asked, your friend is your subject, or somebody from the department, some staff is your subject. So the examiner may allow you to do it over the clothings, but then you tie the cuff over the clothings. But usually it is done over, well, usually means ideally it is done over exposed arm. Now after this, so the elbow joint is also exposed. Where do we keep this? Now what part of the stethoscope we keep on the ventral surface of the elbow joint? The diaphragm of the chest piece, because the blood flow, the turbulent blood flow creating the sound is not a very soft sound. It is a very obvious sound. Bell of the stethoscope is not required for that. It is well picked up with the diaphragm of the stethoscope. So we put, and where we put over the brachial artery. Now this diaphragm is large enough to cover almost the whole of this anterior aspect or ventral aspect of the elbow joint, but we will locate the brachial artery first. Before, why are you laughing? So on the ventral aspect of the elbow joint, you put the diaphragm of the stethoscope, but before that you locate the brachial artery, because that is the part, the blood will not, this blood flow will not occur through some other organ like muscle or something. So it will occur through the blood vessel. So we are doing it, we are choosing the brachial artery here. Venous blood flow, it is not suitable to measure blood pressure, at least by this indirect method. What is indirect method? Actually direct method is that mercury column will record the blood pressure, but how? It is directly, that is putting a cannula inside the artery. So that is invasive. You can obviously understand that practically it is not possible. Just to measure a blood pressure, we do an invasive method. Okay, we cut open and then put a cannula, but that is direct measurement and that is the most accurate measurement. Directly the cannula is put inside the artery and it will record the pressure. The mercury column will record the pressure. It is connected to the sphygmomanometer. The arrangement is made like that, but that is not possible in practical situations. What we are doing is indirect method. We are putting it over the arm, we are creating a pressure over the artery and the sphygmomanometer is overcoming that pressure, then we are recording that pressure. Okay. So, this is the indirect method. So, in indirect method, we will choose obviously the better vessel in from which, because venous blood flow is not arterial blood flow, all this will come to know in theory. Okay, leave that for now. This is arterial. Which artery is chosen here? Brachial artery. Now, the principle is we have to first, like in palpatory method, when I am using the stethoscope, the name of the method is auscultatory method. From auscultation, auscultatory method. Now, palpatory method, stethoscope was not used, but principle was like same, blood flow is being obliterated and blood flow is being restored. Okay. Now also through the brachial artery, blood flow will be obliterated and then it will be restored, then we can record the pressure. At that time we can record the pressure. Now first, to locate the brachial artery, just semi-flex your subject's elbow. You just ask the subject to, every clinical examination requires consent of the subject and the subject should be in a relaxed state. Here your instruction means, as the clinician, who is the clinician who is doing that examination, the physical examination of the subject, he or she is the clinician. It may be a doctor, he or she may be a doctor, he or she may be a nursing staff. Okay. So, the subject is relaxed, and what you do is you passively just arm superior extremity is kept like this, and now it is just passively semi-flexed. As soon as you not full flexion is not required. This full bending of the elbow joint is not required, and by full bending obviously you can't keep that stethoscope, can't use that stethoscope. So, semi-flexion, not very, like 10 to 20 degrees is sufficient. You note in your own hands there is a hard structure over here. That is the tendon of the biceps muscle. You will come to know of the anatomy when you read in an anatomy syllabus. That is the tendon of the biceps muscle, the hard structure over the front of your elbow joint, that is the tendon of the biceps muscle. So, you can easily locate it in your subject. Now, medial to that is the brachial artery, prominent pulsation is felt. If normal anatomy, in a normal anatomy, normal human being, prominent brachial artery pulsation just medial to it. Okay, medial to the tendon of the biceps muscle. By this time, I think you know what is medial, what is lateral, what is transverse section, what is sagittal section. These terms you should have, before starting your anatomy syllabus proper, I think you are now acquainted with these terms. So, medial is towards the midline of the body, lateral is away from the midline of the body. What is proximal, what is distal? Proximal, distal terms were used in the class examination of the arterial pulse. What is proximal, what is distal? Proximal is towards the, loosely said, towards the heart or towards the central axis of the body is proximal, away from the central axis of the body is distal. In that way, see, in the superior extremity, maybe our nails are the most distal things, nail beds and the nails. Okay. So, those are the meanings of proximal and distal, lateral and medial. You should be acquainted. Whenever you use the term medial, one structure is medial to another. That means the medial structure is more towards the midline of the body. One structure is biceps tendon. This, if we speak of these two, there are three things here actually: cephalic vein, biceps tendon, brachial artery and cephalic vein. These you will learn in anatomy. Forget the cephalic vein for now, biceps tendon and brachial artery. So, one is medial, one is lateral. The one which is lateral is away from the midline compared to some other structure. Medial, lateral is said at least when two, maybe more than two structures. If you speak of three structures, medial to lateral, this. You have to describe many relations. As you go through your anatomy syllabus, you have to describe many relations. So, say you are naming three structures, which is medial most, which is lateral most. Medial most is among those three, most towards the midline is the medial most, but it may be lateral to some other structure. Do you get it? So, these you will be acquainted as soon as you. So, say four structures. So, one structure, one of them may be medial to another, lateral to some other. Okay. Say four structures, 1, 2, 3, 4. So, 2 and 3, 3 is from lateral to medial side, away from the midline towards the midline, four structures, say name 1, 2, 3, 4. So, structure number 3 is medial, lateral to 4, but medial to 2, obvious, like this. So, among the biceps tendon and brachial artery is just medial to the biceps tendon, and you can locate it as soon as you locate this heart structure, but if you keep full extension, it is hard to locate. Just flex 10 degrees, 20 degrees approximately, no need to measure. Not that we are taking some mathematical instrument or something and measuring, no, we are just semi-flexing. You get this hard biceps tendon, you locate the brachial artery and put the diaphragm, now the diaphragm of the stethoscope over that. You put the earpiece, will there be any sound? The blood is flowing. We have used the palpatory method, we have restored the blood flow is flowing. What type of blood flow is that? Laminar blood flow. Is there any sound? No. Keeping the diaphragm of the stethoscope, keeping the diaphragm of the stethoscope over the left side of the heart, you get the heart sounds. We get the heart sounds. But keeping the blood through a normal blood flowing through a column of blood flowing through a blood vessel, will we get any sound? Because usual blood flow is laminar, no sound. Now what we do, we have kept, so we use one hand over, non-dominant hand we hold the diaphragm of the stethoscope over the brachial artery, and dominant hand again we are using in the book it may be written right hand, assuming that most of us are right handed. But if you are left handed, you will use the left hand on this pump and the right hand over the diaphragm of the stethoscope. No putting the hand, because you have two hands, not 3 or 10. So two hands are engaged, so no more putting the hand over the radial pulse. One over the stethoscope, holding the stethoscope, one is holding the pump. Now we again pump like before, like in the palpatory method. How much we raise now? Up to which point? Now we are not getting the pulse, so no question of understanding the obliteration of the pulse. How much we rise that up to which graduation? 30 millimeter above the previous recording. Previous recording was 110. In our example, it may be 100, it may be 90, it may be 120, it may be 160, it may be 200. 30 to 40 millimeter above which we had got, that is the reason why we had recorded by the palpatory method. Now we raise, now we are not feeling the pulse. One hand is on the stethoscope, dominant hand over the pump, non-dominant hand over the, this is holding the stethoscope. And the which part of the chest piece is resting on the brachial artery? Diaphragm, and the bell is facing the clinician. Okay, bell is facing above, you may say, or facing the clinician. If the subject is sitting, then the bell is facing towards the clinician. If the subject is swine, bell is facing above, and the diaphragm is over there, kept on the aligned with the brachial artery. Now you see that has been raised. Our reading was in our example 110. We raise up to 140, maximum 150. Now we start to again release the pressure, and very slowly, at least for beginners, very slowly. When we become experienced, doing it a bit faster, maybe we get it, but at least as beginners to learn, during learning, very slowly we release. At one point of time, now how do we feel that the blood flow has been restored? Now when the blood flow is restored through a obliterated or constricted blood vessel, just when the blood flow is restored, there is a sound. Now what type of blood flow? Just at this point, turbulent blood flow, not laminar blood flow. At this point of time, turbulent blood flow, though this turbulence is causing the sound, as this sound is already, the earpieces are in the 2 ears and this is picked up, this sound is picked up. We note the reading. Correspondingly, we note the reading. That is the systolic blood pressure. Now usually sometimes we find this systolic blood pressure somewhat deviates than the what we got through the palpatory method. It is somewhat 10 to 20. Everything as theoretical explanations, leave it for now. You will do CVS theory in the theory classes. Say we had got 110 there, maybe we get 112, 100, not 12, not that, maybe 120, 130 over here. We will record it as the systolic blood pressure. Okay. Now still that is going down. Now the reading is going down. Here it has been recorded as say 120. 110 was in palpatory method, 120 we have got in oscillatory method, and we are still gradually releasing, not sudden releasing. In palpatory method, what we had told, after we get the reading, we may release it faster. But here, after we get the sound, we have to go on releasing it very gradually, and fast the sound becomes somewhat less. Okay. So the first phase where the sound is being created, that is called phase 1 of these sounds. These sounds are named after, who named it? Korotkov, K-O-R-O-T-K-O-F-F, Korotkov. That is in all through our learning, we will get various names of scientists who have done these things. So Korotkov sounds, so Korotkov sound phase 1, the sound is just produced, Korotkov sound phase 1. Then phase 2, sound is somewhat lessened than earlier because turbulent blood flow is being converted to laminar blood flow now. Not yet totally normalized, but turbulent blood flow is being, this is occurring a very short period of time. We are just for explaining, just for understanding, we are discussing it, but this is occurring a very short period of time, but release will be very slow. Turbulence is being created to laminar blood flow. Now the sound is somewhat reduced, then again somewhat increased and maintained, that is phase 3. Then the sound becomes very soft, that is called muffling of sound, M-U-F-F, like cough is C-U-F-F, muffling is M-U-F-F-L-A-N-G, muffling of sound. Now we note the reading corresponding to the muffling of sound, that reading is the diastolic blood pressure. So this is corresponding to the minimum blood pressure recorded during ventricle, recorded during diastole of the ventricle or simply diastole. As we have said, for ventricular systole and diastole, for ventricular contraction and relaxation, we may or may not use the term ventricle, but for atrial systole and diastole, we have to use the term. So during recording blood pressure, we do not talk of atrial contraction and relaxation, we talk of ventricular systole and diastole. Simply we can mention systole and diastole. Got it? So this is the minimum. So during that muffling of sound, what phase it? What phase it is of the Korotkov sounds? Phase 4. Phase 1 to 3 has happened. Phase 1 corresponds to just the beginning of phase 1 corresponds to systolic blood pressure, and phase 4, beginning of phase 4 corresponds to diastolic blood pressure. And after muffling, the sound disappears completely. This is normal recording. Disappearing is phase 5. Disappearance sound is phase 5. Just the sound is disappearing and disappears as a whole, phase 5. Now some authors are saying, so what we have told, how do we record our blood pressure and how do we express it? Expression of blood pressure is like this, systolic blood pressure by diastolic blood pressure. In our example, say we have got at 120 as systolic blood pressure, and say 90 or 84, say 84 as diastolic blood pressure. Okay, so that person's blood pressure will be expressed as 120 by 84 millimeter of mercury. Now some authors in science, nothing is constant. Okay, still there is a doubt whether that muffling of sounds is to be taken as diastolic blood pressure on the disappearance of sound. Which sound corresponds to the diastole or the ventricular diastole? Some authors are saying, that means persons who are working with these things, they are saying that the muffling should be taken. Usually we take the muffling one and we express like this. Say muffling of sounds was present at 84 and complete disappearance was at say 78. Here there is the readings, so 84 and 78. So some authors are saying you take muffling. We should take muffling that corresponds to the diastole. Some are saying 78. We do not enter into ambiguities. As beginners we say we take muffling of sounds and say systolic is there is no, that is the appearance, turbulent appearance, sound is coming back, not coming back, sound was not there. Blood flow is coming back through the obliterated artery, so sound is being produced, that is the that point the corresponding reading is the systolic reading, but diastolic there is a confusion, okay, among the authors. So we usually take the muffling of the sound as the diastolic blood pressure and write it as this. But so as there is an ambiguity, sometimes we say we have taken, in our example we have taken it as 3 readings, 120 appearance of sound, 84 phase 4 as muffling of sounds, and say 78 disappearing of sounds. There will be not much difference between, not 10-20 difference, usually 6, 8, 10, maximum 10 difference between the muffling and the disappearance. Got it? Muffling and disappearance. So say 78. So sometimes we are writing, if we write we try to be very accurate, then 120 by 84 by 78. That is, instead of systole by diastole, we write is systole, but that is systolic BP. Then that 84 is called first diastolic BP. BP means blood pressure by second diastolic BP. But no need to go into these complications as beginners. Just you write. Don't mention first and second diastolic, not like this. You take baffling. This is just for your learning. You express as systolic by diastolic. That means sound production phase 1 by phase 4. Okay, got it? But sometimes we can write systolic by first diastolic by second diastolic. But no need to go into these complications. You write systolic by diastolic. That means the first diastolic you write simply as diastolic, systolic 120 by 84. Okay, this is the blood pressure of the person recorded. So this is how to record blood pressure. Okay, theoretical aspect you will come to know in the theory. This is how to measure blood pressure and record it. So we have to practice it now. Now history taking and general examination, there was class, probably you are not being able to say whether general examination was discussed. Just in short we will do. History taking is any subject comes to us. What is the difference between subject and patient? Subject is who is coming for a medical consultation. Any person who is coming, maybe just actually he does not have a disease or he is just feeling it. That is, the feeling is, any feeling is called subjective, because that is, a subject is having a feeling, that is the subject. Any individual who is thinking that may have some disorder, physical disorder. Okay, so that a subject, whenever you diagnose as a clinician, whenever we are able to diagnose actually a medical illness is present, then the term patient should be used. So in most cases, we in physiology will use the term subject. Subject is any individual who is coming for medical consultation. So history taking is knowing about why he or she has come to the clinician. So at least for as beginners, the discussion will be somebody is coming to the outpatients department or clinical settings. Anybody may present to the emergency, then obviously is a medical illness. So then he or she may be called a patient. If she or she presents with an emergency, a person presents with an emergency, probably to the emergency room, then immediate admission may be required, etc. But for now, just concentrate outpatients department. What are the things to be noted? First is history taking. What is history taking? Just getting an idea about why that person has visited this clinician. Okay, so clinician is ourselves, the doctors. So why that person is coming to the doctor, we have to note that. So first we note the patient particulars. What patient particulars means? Name, age, gender, occupation, address. If not the full address, at least from the locality from where, because all these are important except the name. Name does not, obviously name does not have any bearing on what type of the patient's name does not have any bearing, but age, gender, everything has a bearing. There are diseases related to age, obviously old age, in childhood, diseases related to the age of the subject, diseases related to the gender of the subject, that depends on the gender of the subject. Localities, in some localities, some areas, some say from a very where the living conditions are not very healthy. The person is coming from a slum area where the living conditions, so chances of these communicable diseases like malaria, tuberculosis more. So those are important things. Where from the person is coming, and also the occupation. Say persons working in industries where there is a lot of dust and all, respiratory diseases are prevalent. So these are all important things. Okay, to note in your part of the history taking, just the patient particulars. Then history of present illness. You had a class on Monday. I think you have heard these terms. History of present illness, that means describe why you have come. Okay, so that person will describe some symptoms. Now what is symptom and what is sign? Just know these terms given in the book, know these terms. Symptom is the subjective expression of his or her feeling, what the subject speaks. I have pain, I have fever, like this. These are symptoms. But what are signs? Correspondingly, the clinician, what findings which the clinician gets, that is the signs corresponding to the symptoms. So the subject is complaining of pain. Say subject says, I have pain over the front of my belly. So what as clinicians, what we do, we put our hand over the belly of the subject and we record some tenderness, say in the right upper part of the belly. Belly is a layman's term. So we say medically it is called abdomen. So this part, the belly part is called abdomen. So we will say there is, what is that? We will not say pain, because pain what is felt by the subject himself or herself, that is a symptom. We say tenderness, that whenever we keep the hand over there, the subject expresses that he or she can feel the pain. Then we write there is tenderness. As a clinician's note, we write there is tenderness over in the right upper quadrant of the abdomen. Quadrants means dividing into 4 parts. During GI system examination, we will come to know. So this is an example of pain is complained by the subject. Complaint is pain, that is a symptom. Tenderness is the sign. Complaint is fever. Sign is the rest temperature. What you get, what as clinicians we get, is the rest temperature. We will not. So we are getting fever. Fever is the complaint. Fever is a subjective feeling, but rest temperature is the clinical finding. Okay. So this is the difference between symptom and sign. Now the person speaks of symptoms. So here he or she has come from history taking. When you go by the bedside of the patient in medicine, you will learn in more detail. But for now, you know just the brief headings under which history taking is done. History of patient particulars, then history of present illness, then history of past illnesses. The subject will probably not describe past illnesses by his or her own, because he or she is a layman, he or she is not probably a medical person. So he or she will not be able to relate it that I had typhoid 15 years ago, so this may have relation, but sometimes it may have a relation to this present illness also. Not in typhoid, usually not in typhoid. This is a bad example for this, but say here's some lung disease. There is a chronic lung disease called chronic obstructive lung disease. You will learn in your first year of medical school only about this disease, chronic obstructive lung disease. Now these do not go away. Diseases like gastric ulcer or peptic ulcer, okay, chronic obstructive lung disease, these are not curable. These are just controlled by medications, but sometimes they exacerbate. Say a person with peptic ulcer or a person with chronic obstructive, usually during the winter season, a chronic obstructive lung disease, or persons who have asthma since childhood. Asthma is they are passed on hereditary asthma. A disease which is passed on. So asthma is prevalent more in childhood, then it is controlled by some means, but in maybe they are using medications like inhaled medications. Have you seen inhaled medications? Through inhalation method. So inhaled medications, but sometimes they flare up, especially during the winter season. So the subject may not know this, he or she is not a medical person, but you have to relate that history of this is present for a long time and this is just an acute exacerbation, this is not a new illness that never occurred in lifetime, not like that. So everything is important during history taking, and as clinicians, especially if the subject is his or her first visit to us, then we should take detailed history and the question should be open-minded. These details you will come to know later when you do medicine classes. But what type of open-minded? Don't concentrate on, don't make your that thinking narrow. No, they're just okay. I have chest pain, so you should relate that chest pain. There may be associated things. This comes by experience, and you first try to know. You allow the subject to talk freely for say 1-2 minutes, like whatever. Now all things which he or she speaks up is not relevant, and this is also maybe you are not being able to relate that now, but after you carry on, you are going on in your medical school, you will learn various types of disease and what to ask. So be open-minded in asking questions, not just concentrate one particular symptom. Okay, so this is the diagnosis. What is diagnosis? The idea, the diagnosis. That means through our medical knowledge, what conclusion or inference we arrive at, that this may be this. Then you will, this diagnosis, your clinical diagnosis is supported by lab investigations like blood tests. These days are CT scans, X-rays, so many things have come. Medical science has developed so much. So those will support your clinical thinking. But before that thinking, your thinking should not be narrow. That means, okay, so this person has respiratory trouble, he is saying he has asthma, so this is acute. That may be a separate respiratory disease also. So for that you have to ask whatever information all informations will not be very relevant. Some informations you have to ignore with your experience as a clinician, but history of present illness, history of past illness, some diseases are hereditary, so you have to take family history. So you are suspecting diabetes, so diabetes is passed on from one generation to another, whether that father or mother or does he or she know that his grandfather or grandmother, somebody in the family or suffered from diabetes or not. Also first degree relatives, maybe father has not suffered but uncle has suffered. Okay, so these histories of family history, any addiction history, smoking, alcoholism, these has relations to various diseases. So these histories you have to take, family history, personal history, what is the kind of lifestyle. So these are some broad headings, there are details of it. History taking is a vast thing, details by experience you will learn when you do your medicine course, diabetes course, surgery course in the later years. And then again, if you do specializations, after MBBS, if you do specializations, relevant history taking on various diseases you have to, and by experience you gather. But these are some broad headings, just an outlook, how to take history. Patient particulars, history of present illness, history of past illness, family history, addiction history. These past history also includes any history of any surgical intervention earlier. If you are examining a pregnant mother, okay, so what histories you have to take? Your past obstetric history, all this you will learn in gynecology and obstetrics. Past obstetric history, whether he or she has any child before, any female of the reproductive age group, whether he or not he or she, sorry, she has born any child before. If more than one child, what is the time of the last childbirth? Menstrual history, okay. Whether, say you are examining as a patient, your subject is a woman aged 60, probably menstruation has stopped, the person, that individual has attained menopause. So what is the time, what is the age, approximate age at which he or she, all these are important. You will see related to various diseases. After menstruation, after menopause, females, some females develop osteoporosis, causes you will know in your later. So if you have to diagnose that thing, you have to know these relevant histories. So all these come, menstrual, in case of females of reproductive age, menstrual history is another history which you will have to take. So these are general guidelines. You will, when you do the various clinical subjects classes, you will come to know more. Okay, this is history taking. And general survey, just general examination. Examination of the examination is physical examination. Right. All these have gone out of order. These have to be discarded. Physical examination. General physical examination and systemic. Systemic physical examination is examination of the systems, physical examination according to the systems, going by the systems. How the human body or any living body, multicellular living body, how do we describe the organization of the human body? Cells are forming tissues, tissues are forming organs, organs are forming systems. So systemic examination is like in your syllabus you have examination of the respiratory system, examination of the GI system, examination of the cardiovascular system, examination of the nervous system. Okay, not everything related to it. As for beginners, in your beginning of your course in your first year of medical school, some things are there from each of these systems, that comes under systemic examination. What is general examination? Just general, or also called general survey. The person has attended your clinic and just some usual things you need to note before proceeding to systemic examination. So what are the points under which general physical examination is done? First is just by looking at, that is called inspection. Inspection, palpation, percussion, auscultation. Just by looking at, without touching or feeling your subject with your own hand. Your means the clinician's own hand, just by inspection. Appearance, includes build and nutrition. So obviously a very lean and thin subject comes to your clinic. Okay, so there you may be very lean and thin or very obese. extreme. So you may be required just to measure the mid-arm circumference with a measuring tape. So this is one of the findings of the, so obviously to measure you are no more, only inspection is not possible. You have to touch your subject. So that is appearance, build and nutrition. Just by looks, how, just as the person is entering your, he or she is walking into your clinic, you note the what? Manner of walking, that is called gait. So these are some points to note in general appearance, gait, not GATE. Like there is a difference between CALF calf and CUFF. GATE is that this gait is manner of walking, GAIT. Whether the person is walking straight or whether he is tending to, maybe he or she has some defect of the nervous system, some lesion of the nervous system, so not able to maintain his or her posture. Okay, that is you have to note. So just by appearance you note that the gait is not normal. Okay, the build and nutrition is not expected for the subject's age. Okay, a very lean and thin in old age due to some malnutrition may be indicated, very lean and thin, malnutrition or very obese, all this in general appearance. Next is, this is number 1 point. Now number, I say after the first point, okay, we divide into, at least how many of you are interested in football? Okay, how do you describe a system in a football system? Like goalkeeper, one is goalkeeper, then the defense, midfield and the attackers. Okay, so we describe like this 4-4-2 or 5-3-2 formation, 3-5-2 like this. Those who of you are acquainted can relate with this, but at least I say first is appearance, 1. Now we divide it into, next 3 points are pulse, blood pressure and temperature. Okay, so pulse and blood pressure we have learned, recording of arterial pulse and recording of blood pressure, this comes within the purview of general survey. Whenever you are doing your general survey, you have to, not that pulse and blood pressure are related only cardiovascular system examination. Okay, so before just you person comes to your clinic, we are a general physician, and without recording the pulse and blood pressure, no, I don't know that, you have to go to the heart specialist for that, not like that. So general survey, pulse and blood pressure are including for general survey. So not the cardiovascular system examination, no, pulse and blood pressure is part of our, is related, the theory is related to the cardiovascular system, but this is, you have to measure, see in general survey only. So pulse, blood pressure, temperature just speak together. You have to remember these 11 points, but just for convenience you remember 1, 3, 5, 2. Next 5 are, just remove this. Four, 5, 6, no, sorry, 5, 6, 7, 8, 9. Calor, I am sorry, this, most of these you have to. So on Monday, were these things discussed? So why were you telling not discussed? At least you should remember the names of the headings. If you don't know the headings, what we learned? Pallor, cyanosis, jaundice, clubbing, edema. Okay. What is pallor? Paleness, paleness of the skin. What is cyanosis? You will come to know all the definitions in the theory. Just hear it for now. Just listen now. Bluish discoloration of the skin or mucous membrane due to reduced hemoglobin. Explanation you will learn in the theory. Due to, because if we go on discussing theories here, that is not the aim of the practical class. Aim of the practical class is practicing the clinical methods. Pallor is paleness, usually related to anemic subject, but even without anemia. What is anemia? Is reduction in RBC or hemoglobin below a certain level. Okay, so normal hemoglobin levels or normal RBC level is coming down, causing pallor. That means paleness of the skin. But even without anemia, when a person is very frightened, the face may become pale. That is also pallor. and you have to note it in your clinical examination. Then you have to go on into understanding whether that will be supported maybe by lab tests, whether this is due to anemia or whether this is just temporary paleness. But pallor is pallor. And don't write this term as anemia. We are not seeing anemia in general survey. Anemia cannot be diagnosed by general survey alone. Anemia is a clinical diagnosis plus lab supporting investigations are required. So you use the term pallor over here. If any book has, maybe some books have written it as anemia, don't go by that. Maybe go by the term pallor over here. Then cyanosis. Blue is discoloration of the skin or mucous membrane when the hemoglobin, reduced hemoglobin comes below 5 gram %. Okay. So it is noted mainly in the where the skin margin is very narrow. That is like in the lips, this is noted. We will come to the sites where to examine. Then what is jaundice? Yellow is discoloration of skin and mucous membrane. Usually note in the eyes, but we will note the sites. Clubbing is obliteration of onychodermal angle. What is onychodermal angle? See your nails. If these are normal, then this skin on the dorsal aspect of dorsal aspect of the fingers and between the nail bed there is an angle which is less than 180 degrees. This is not straight. See, there is an acute angle. No, should not say acute angle, not less than 90 degrees, but less than 180. This is not straight. If this is obliterated or if this is swelled up, then that is called clubbing. If this angle is obliterated, that this skin and nail bed becomes straight, that is clubbing. It is seen in some respiratory diseases elsewhere where it is seen, and there are degrees of clubbing. Don't need to go into those details as beginners. Just know this is clubbing and how to examine clubbing simply. In medicine you will learn clubbing is 4 degrees, 1 degree, 2 degree, 3 degree, 4 degree. Later, not for now. Just for now, concentrate. This is pallor, this is cyanosis, this is jaundice, this is clubbing. Edema is so swelling. That means swelling. Grossly, loosely you may term swelling. This is due to accumulation of tissue fluid in some parts of the body. If the whole body is swelled up with tissue fluid in generalized diseases, it is called, the term is anasarca. All these terms you will come to know later. Anasarca, ANASARCA. For now you know edema. Pallor, cyanosis, jaundice, clubbing, edema. We will note the sites, so we will do the clinical examination. Pallor you may just write down for now, or you may not write down. Everything is in the book. Pallor we note in the. Actually, today I am taking 2 classes together, so I am going slightly fast. But you will, as you practice, you will come to know all these things. Pallor we note in the lower palpebral conjunctiva. What is it? Just by putting this lower eyelid down with the clinician's hand, we use the hand and we note the lower. We ask the subject what is our instruction to the subject. Relax and just try to look upwards. This is our instruction while seeing pallor, and we. With our finger, we just lower this lower eyelid and the lower palpebral conjunctiva can be seen. There is a redness. Okay, just you note in your friends, there is a redness. So that is how. If that is pale, we may say there is pallor. Okay, don't do it just now. Just listen now and then we'll do it. So pallor, it is noted in the lower palpebral conjunctiva, but this is not the only site. The tongue becomes pale if grossly anemic. Say hemoglobin has gone down to say 8 gram %. So tongue will be somewhat pale. This redness of the tongue will disappear. So tongue is asked. You ask the subject to protrude the tongue out like this, and you note. Noted in the nail bed. See, nail beds are reddish. There is a reddish tinge on the nail beds that may disappear. Not disappear completely. According to degree of your pallor, it will be mild, moderate, or severe. But you note the nail beds. You ask the subject just to open your hands, not like this, like this. This is Shah Rukh Khan. So this is just to note the hands. So this is, you note whether this reddish tinge is going up. That is how to note pallor. Okay. So cyanosis. So these are some. So if the severe pallor, just by looking at, even without examining, you see the whole face has turned pale. The exposed body part, say the superior extremity is exposed, so that those have turned pale, that is obvious. But if you have to note, say mild pallor, so you have to note as a clinician, even you have to pick up mild pallor and be cautious that whether there is any reduced hemoglobin or something. So that is just, so general survey you do. Pallor, what are the sites? Lower palpebral conjunctiva, tongue, some common sites, lower palpebral conjunctiva, tongue, these nail beds, this palm of the hands, okay. And always, like in blood pressure measurement also, ideally you have to do both sides, and ideal measurement of blood pressure is 3 readings on the left hand, 3 on the right hand, and each reading has to be 5 minutes apart. Practically it is not possible to give 30-40 minutes for measuring blood pressure alone. But if you have to, if there is some call, you have to blood pressure very carefully. In the inpatients department, sometimes we may require that we are measuring the patient is completely relaxed. Anxiety will raise blood pressure at least to some extent. So patient in the inpatients department, complete in the ward, admitted in the ward, completely relaxed. We are taking at least 2 or 3 readings one after another, maybe 2 or 3 in the left hand, 2 or 3 on the right hand, alternately like this. Even if you take 1 reading, okay, for pulse and blood pressure, pulse you have to do, you have already learned examination of the arterial pulse, you have to compare the radial pulses of the 2 hands. So this is bilateral. Pallor also bilateral in most cases. We don't have 2 tongues, we have 1 tongue. So during seeing the tongue only once, but both eyelids like this, okay, together. Tongue, both hands, not like this only, okay. So both hands, okay, both nails. So whatever in clinical examination, whatever bilateral is possible, we do bilateral. Whatever is not possible, that cannot be done bilaterally obviously, but whatever is possible bilateral, you have to do bilateral. Pallor. Cyanosis, the most common site where it is noted is these lips, margin of the lips, because the skin is thin, it is easily noted. And if there is gross cyanosis, very high degree of cyanosis, obviously the blue, these nail bay, everything will become bluish. That is cyanosis. Jaundice is yellowish discoloration. Most notable is in the upper bulbar conjunctiva. This time the subject is just relax, ask your subject just relax and try to look down, and you hold this like this up and note the upper bulbar, there is a yellowish tinge. Again, in very high degree of jaundice, maybe the whole skin is looking yellow just on inspection. Yellow is all the exposed parts of the body are looking just on inspection. But if mild, then most convenient to pick up in upper bulbar conjunctiva. Okay. Also the under surface of the tongue. So see, actually during learning we are learning like this, but during actual, once you should not make your subject is a living human being. Don't make him or her uncomfortable. Like once you say, oh, now I have to note pallor, protrude your tongue out. Now you see cyanosis. Now you again remember, oh, I have to look for jaundice. Protrude your tongue out. So he or she will feel uncomfortable. Once the tongue is put out, you just ask, protrude your tongue out, just reverse your tongue. You instruct the subject, you note pallor, jaundice together. Not like one by one. For the sake of learning, we are learning one by one. But during even motor movements, we will do motor system examination in the nervous system examination, whether the tongue muscles are moving properly. For that, tongue examination means, so when we again learn it in medicine better, you go by the parts of the body. Some standard authors are describing like that. General survey, first you do the head and face, everything, then you do the neck. But as beginners, I think it is better to go by points. But when you have learned the thing, you are doing actual general survey on your patients, go by that. So tongue you note, pallor, jaundice, tongue movements, everything you note together. Not like, okay, pallor, okay, jaundice, now again then the subject will feel uncomfortable. Clubbing. As beginners, I would recommend seeing like this from the horizontally, some books are writing, see, if there is this angle, you oppose the thumbs like this, there is a diamond shape in the middle. You see, oppose both the thumbs. There is the normal onychodermal angle. Onycho means related to nail bed or nail, dermis is related to skin. Onychodermal angle named after whom? Lovey bond. Okay, LOVI, the person who described Lovey bonds angle, it is also called Lovey bonds angle. LOVI-BOND, Lovey bonds angle, that onychodermal angle, see there is a space. But if this becomes flattened, this space will be reduced. But as beginners, it is better not to see like this, you may misjudge it. So see it just like this. If you see like this, it will not be possible. See it just whether all are at the same level. At the same level with your eye, put the fingers of your subject at the level of the eyes and just look at. Okay. So if there is any clubbing, ignore the thumb then, just at least these fingers, you can see clubbing, okay. You have to bring to the level of the eye. This will happen, you will, as you go on practicing more, clinical methods will be, what are clinical methods? These are sets of skills. Based on your knowledge, you are using your skills and doing the methods. So these methods require practice. First day it will not be perfect, even nobody is perfect, okay. Just by gathering experience and all through your medical life, all through all hours also, all through our medical life, you will see concepts are changing. So you have to update yourself. A professional course is not like this, whatever you learn in your first 3 or 4 years, that will go on. So concepts will change, you have to update yourselves. But basic things you have to know. So what to see in general? So these are the clubbing. Then you need edema. A patient is lying down, just where to note edema, that swelling, best place to note is pedal, this is called pedal edema in the legs, just above the medial malleolus. Do you know by now what is the medial malleolus? This is the medial, prominent medial aspect of the bone in the medial part of the ankle, that is the medial malleolus. Another prominence is on the lateral part of the ankle, the side of the ankle, that is the lateral malleolus. Just over the medial malleolus, what we do? Press it with the thumb for 20 to 30 seconds. If there is very large swelling, that will be apparent only pressing for 5 seconds. But as beginners, you press at least for 20 to 30 seconds to get habituated. As beginners, we learn on our own friends. Okay. So most of us are expected, we are all physiological. So there will be no edema, there will be no accumulation of, usually fluid is not accumulated. So we press above the medial malleolus, keep that, press it for 20 seconds say, and release it. If there is edema, that depression will remain for some time, okay. So this is how to note edema. Again, we have to note bilaterally. Whatever possible to note bilaterally, you have to note bilaterally. And 10 and 11 are neck veins and neck glands. Neck veins, one prominent, one important neck vein is the jugular vein. Neck veins and neck glands, okay. Neck veins. So after we are done with a bit of theory in CVS, we will learn more of the how to see neck veins. That is jugular vein, neck vein, veins present. One of the veins present in the neck is neck veins, examination of neck veins. And neck glands, just one of you come forward, just volunteer. Don't take so much time in deciding who will come forward, okay. Bring your chair, keep those things and bring your chair. So most are present today. Yesterday's attendance was only 27. There were lot of empty chairs. Na ekhane dekhte pabe na. Eikhanta eso. Eikhanta eso. ঠিক আছে উনি থাকুন. If anybody cannot see, just let me know. We will repeat it. বসো. Now see, usually একটু এগিয়ে usually neck glands, lymph nodes, how it examined from the back, okay, like this. So these are there will be prominent. There are the salivary glands and all other lymph nodes, axillary lymph nodes, etc. When you go through the anatomy, you will learn. So from the back we see, and bilaterally to save time we see it together. Suppose these glands are inflamed, okay, they are swelled. In normally you will not find, but just by looking like this you will just see, okay, like this. If you find, if the person is already complaining of swelling on the axillary region, like this, you put the hands in the axillary region and palpate for the, this is palpation. Using the hands, this is called palpation. So palpating the neck glands and neck veins will come later, neck glands. Just remove your spectacles. Just relax, look up, try to look up. So this is noting for pallor. Protrude your tongue out. Not whole tongue out, okay. Ask your subject protrude. That is looking for not anemia, pallor. And immediately you ask the subject to reverse his tongue so that you note the undersurface of the tongue, jaundice together. So just if you ask your subject, some subject, if you don't need to instruct verbally, just do yourself, the subject will do that, note for pallor, okay. Note for the nail beds like this. All these pallor, cyanosis were in the lips, and edema You have to make your subject supine and note above the medial malleolus. So 1, so go there. Thank you. So 1, 2, 3, 4, 5, 6, 7, 8. Except this, some books are writing, or you may also include respiration, but that is a part of the systemic examination respiratory system. At least respiratory rate counting, you do it in the general survey. Okay, counting the respiratory rate. Your subject is lying down. Obviously, for counting respiratory rate, the chest and the abdomen has to be exposed. Okay, so you count the respiratory rate. That respiration is going on, counting the respiratory rate. We will learn how to do it in the respiratory system, but sometimes we include it in general survey also. But at least these 11 points. Okay, so 1, 3, 5, 2, 3, 5, 2. Pulse, blood pressure, temperature. Next 5 was pallor, cyanosis, jaundice, clubbing, edema, neck veins and neck glands. These are the points to note, and also you may include the respiratory rate here. Some people are saying even the thyroid gland examination is included in general survey, but usually we don't put it under general survey. That is the examination of the, when the systemic examination is done. During examination of respiratory system, together we examine the position and palpate. That will, you don't just by inspection, if there is a thyroid gland swelling, that may be evident, but you have to palpate also whether it is deviated or not or something. So that we do with the examination of the respiratory system, which we will learn after this general survey and history taking this part is complete. So at least these points for general survey. Okay. So what appearance, that includes build and nutrition and gait, pulse, blood pressure, temperature, pallor, cyanosis, jaundice, clubbing, edema, neck veins and neck glands. Okay. Now today we discuss blood pressure and history taking general survey. Only 10 minutes are left. If you are willing to, you may go to that room will be there. You may practice if you have some time. Otherwise, there is not much time left. These 2 classes actually cannot be done in 1 class. And some of you are saying no. This will, okay, today there is no more time, not much time, but clinical methods you have to practice. Only by listening to your teacher or just knowing the theoretical part won't help. If you don't practice, you will commonly make mistakes. What? Just be quiet for some more time. Class is not yet over. I am saying in 10 minutes you cannot practice much, but all these things you have to practice among yourself also, whether in your hostel, whether in your common room. Make a group and practice clinical methods. Now, without practicing, you will surely make mistakes. You will not even forget to see pallor, edema, these things bilaterally. In fact, edema at least we could not demonstrate here. We have to make the subject lie down and press over the medial malleolus. So a bit of learning is left, but you said you didn't have any class on blood pressure, so I discussed a bit of blood pressure also. How to measure blood pressure, that is also to be done. So let me see, we may do it next Monday, or if you have to proceed, because other batches had classes on blood pressure earlier. You are telling you didn't have. So examination of blood pressure, general survey, at least without clinical examination does not require. Maybe temperature measurement requires a clinical thermometer. If clinical thermometer is not available, you just put the dorsal surface of your own hand over the forehead, over the neck of the subject, and just write it as raised temperature. The subject complains of fever, you will probably get raised temperature. Put the hand like this over the forehead. Okay, here there is no place of doing it bilaterally. Okay, put the dorsal surface. This is the method, but you have to practice this method. If you don't practice during the examination, you will see that out of anxiety or something, even we are putting like this. This is not a correct method. We put the back of our hand. This is more sensitive. So, pulse, blood pressure, temperature. What are the points? Just so some of you responded like already we had have 1.5 hours of the class, so it is already done. So without clinical practice, it will not be possible. Okay, 5 minutes is not sufficient, but we may have to continue with it. Blood pressure measurement we have to see, and general examination we have to see. So, what are the points in general survey? Appearance, including build and nutrition and gait. Any other obvious appearance, if there is a large swelling in the face, you will note it. Okay. So, appearance, and then pulse, blood pressure, temperature, 3. Next 5, pallor, cyanosis, jaundice, clubbing, edema. And next, neck veins and neck glands. Points in history taking. Yes, patient, first is patient particulars. Name, age, gender, address, occupation. Name, age, 5 points here also. Name, age, gender, address, occupation. Okay? So, related to medical diagnosis, name is not important, but obviously for identifying the subject, name is important. Next is history of present illness, history of past illness, family history, personal history, in females of reproductive age group, menstrual history, okay, addiction history, okay. Grossly, these are the points. And blood pressure, how have to measure, palpation and auscultation. So, I think when we need classes, I think we will try to do it on Monday, okay. I think we would have, if you had learned this on Monday, today we had practiced it, okay, now we will require another class. Otherwise, from Monday, we would go on with the respiratory system. So, we will do it on Monday. Practice, no more, that means this lecture part that day, only practicing blood pressure, how to measure blood pressure and history taking and general survey. That is the class on Monday. Okay, thank you.